Good morning, everybody. Sanibonani. We can start singing. Oh, woman, oh, she's a woman. She's a fighter. No woman, no cry. Uzabalaza, zabalaza, zabalaza. We zabalaza, zabalaza. Uzabalaza, zabalaza, zabalaza, uzabalaza, uzabalaza, zabalaza, zabalaza, uzabalaza, zabalaza. She's a woman, no woman, no. She's a leader, no woman, no cry. She's a woman, woman, no cry. She's a fighter, no woman, no cry. Uzabalaza, zabalaza, zabalaza, uzabalaza, uzabalaza. Uzabalaza mandla amandla eyokugcina before we start ithi enye kancane sekusele kancane kancane sizophumelela hayi sekusele kancane sekusele kancane kancane sizophumelela elembombo sekusele kancane eFree State sizophumelela Western Cape sekusele kancane KZN sizophumelela kancane sekusele kancane kancane sizophumelela kancane sekusele kancane kancane sizophumelela Eastern Cape sekusele kancane eGauteng sizophumelela amandla 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 all power thank you comrades and friends. Good morning, sanibonani, dumelan, abshen. Again, igama lami ndingu-Anele Yawa. I am the General Secretary of Treatment Action Campaign, as well as the Chief Accounting Officer of the Ritshidze project. Before we start, I will ask us to rise and have a moment of silence who succumbed to in our facilities. Also, in the room, we have colleagues from the Provincial Department of Health. We have Mama Upe Ofeng, Ume Koseli is an OPM. Kobet is an OPM at Boiketelo Clinic. Ume Mosia OPM at Bushatitaba. Mononcha. Futati chaba mononsa zanixolela mlo ke bonile ndiyathetha and Bolata. All of you colleagues, you are welcomed in the room. Unfortunately, colleagues, as I indicated earlier on, we were supposed to have started at 10, but it was gonna look bad for us to start at 10, yet the district officials were not here. We accept your apology in advance, officials from the district. The time now is, on my phone, is 10:25. We're gonna start our meeting without wasting any time, colleagues. I know that there are colleagues who will be giving oral testimonials. I so wish that when we talk, short, brief, precise, straight to the point, as long as we're making sure that the message and the content of the message has been passed. Because the more we prolong our testimony, is the more we're gonna eat time. And if one person took 10 minutes, the other one will take 10 minutes, we will end up finishing at 10. So the first one who's gonna speak must think for the other, and the other must think for the other. And then towards the end, we will give the department an opportunity to respond. Umama has a hand. I think we do have a roving mic. Or you've got a shop steward voice like me, ma'am. Or Kutiwa, the district manager for Thabo Mofutsanyana, is online. Let me take this opportunity to welcome everybody in the room and those who are online. Without wasting any further time, here in front, I've got my comrades, whom I will give them an opportunity to introduce themselves, because we will be working together. Let me start on my right-hand side.
Sanibona, ndingunondlela Mpambaniso, Free State District Organizer, Ritshidze.
Sanibonani, igama lami nguMary Wakanyathi. I'm one of the project officers abasebenza no Ritshidze.
Kgotso. Lebitso la ka ke Thato Lobaka, nna ke the Key Populations Monitor Monana Free State.
Thank you. And I'm there, and then there at the back, we've got comrades who are busy working on this to make sure that we are connected all over the world. We've got Honorable Loti, we've got Honorable Ndivuo, we've got Honorable Maureen. We are all together. So I think I have welcomed everybody, and I've welcomed the comrades behind the camera, as well as Rayan. Everybody is welcomed. So all of you feel free, feel at home. Let's engage, colleagues. Let's talk to each other. The reason we are having a meeting like this is nothing else except for us as the public healthcare users to work with the Department of Health, to work with the government, to improve the quality of services that are meant for people living with HIV, to improve the quality of services that are meant for key and vulnerable populations. As it stands, colleagues, in South Africa, we've got more than 100 facilities in 17 districts that are not doing well in meeting the second 95 and the third 95. And we are not talking here about few numbers. We're talking about thousands and thousands of people who have disengaged on care due to a number of reasons. And these are not just numbers. Behind each and every number, there is a life of a person. It can't be true that during the dark days of AIDS denialism, when Thabo Mbeki and Mando Tshabala Msimang refused us antiretroviral treatment, we used our anger. We used the courts of law until we won the battle. That's why today we are proudly saying South Africa is managing a program of antiretroviral, a biggest program across the world. It is not because of the willingness of the government. It is because, as Treatment Action Campaign, we took Thabo Mbeki to court for the prevention of mother-to-child transmission therapy. We took Thabo Mbeki and Mando Tshabala Msimang to court. Today, we've got more than 5.6 million people on antiretroviral because we forced our government. We are no longer there now. We are working together to save lives. It does not sit well with us as people living with HIV to see majority of our colleagues being denied the life-saving treatment in our facilities. It does not sit well with us as treatment action campaign and the sector of people living with HIV, seeing the majority of our people being denied their constitutional right as enshrined in Section 27 of the Constitution, where people will go to facilities and will experience all these unjust acts. In South Africa, we've got what is called a Patients' Rights Charter. We've got a constitution. We've got all these laws and nice documents. But what is important, how do we make sure that what is in these pieces of paper, how is it translated into reality when we go on the ground? How do we make sure that after 1994, how do we make sure that the people of South Africa feels that this is their government? How do we stop that mentality of black people oppressing other black people? How do we make sure that those who are in positions of power begin to understand and respect the rights of the people of South Africa, those who stay in South Africa, and those who work in South Africa? How do we make sure that we respect what is in the Bill of Rights? How do we make sure that when we go and work for government, we apply everything that the government says we must do, and not say, according to my culture, according to my religion, according to this, I cannot do this? We've got majority of young people who are denied TOP services in some facilities because some healthcare workers do not believe in that. We've got majority lesbians, gays, bisexual, transgender, and all of them who are denied services in our facility. Africa, as I'm talking to you, we are moving towards the NHI, the implementation of the NHI. And there are many people within the private sector who do not want our government to implement NHI. And the more we fail on the ART program, the more we have more than 100,000 and more people living with HIV who have disengaged on care. We are giving a weapon to those who are under NHI to say, how do we expect NHI to work if the ART program is like this? That's why we need to work together and make sure that we improve the quality of health services, not only for HIV and TB, for health services across, so that we can bring hope to the people of South Africa. People of South Africa are patiently waiting for the NHI to be implemented. We need to bring hope to them. And the only way to bring hope to them is only when we fix whatever problems that are within the system. Without making State of the Nation address, with those few words, I was trying to welcome you and try to bring our minds together and understand why we are here. On that note, I will hand over to Comrade Mary to take us. I'm sure all of us, we do have a program in front of us. We are now on 2A. Comrade Mary will take us, will lead us from 2A to 2G, and then we will take it from there. Over to you, Mary.
Ngiyabonga, GS. Today we're launching the third edition of the State of Health report for the Free State Province, developed using data from the Ritshidze community-led monitoring. Ritshidze monitoring takes place on a quarterly basis in 20 facilities across the province. This week, we will hold 2 community accountability meetings. One is today in the Thabo Mofutsanyana district and tomorrow in the Ritshidze district. We will be deep diving into both the progress and challenges across the 2 districts to hear directly from people living with HIV, people who use drugs, sex workers, the LGBTQIA+ community, and other people, other healthcare service users of their real experiences using clinics in each district. Today, as we start with Thabo Mofutsanyana, where we monitor 10 facilities, the data was collected through observations as well as interviews with healthcare users, public healthcare users, people with HIV, key populations, and healthcare service providers, for example, facility managers and pharmacists. The data in this report was collected between April and May 2023. Interviews took place with 11 facility managers. Observations took place at 11 facilities. Interviews took place with 615 public healthcare users, 46% of which were people living with HIV, and 20% identified as young people or people under the age of 25. Additional data was collected between July and September 2022 among communities of key populations. Interviews took place with 49 gay, bisexual, and other men who have sex with men, 110 people who use drugs, 92 sex workers, and 29 trans people. It's not working. Additional quantitative data related to the availability of HIV prevention was collected between June and July 2023. Data collected took place at 84 additional sites across the province, including 20 in Thabo Mofutsanyana. I'm going to hand over to Tato to discuss staffing and waiting times.
First, down from care users interviewed in the province think the waiting times at the facility are long. This has worsened since last year, where 63% of public healthcare users thought the waiting times were long. 45% of public healthcare users blame long waiting times on staff shortages. 29% blame staff not working or working slowly, and 64% blame the fact that it takes too long to find files. Filing systems are messy and files get lost. In fact, filing systems were observed to be in a good condition in only 18% of sites monitored, down from 25% last year, mostly due to filing rooms being too small to maintain. Messy and disorganized filing systems increase delays and increase the burden on already overstretched healthcare workers. Positively, the average earliest arrival time has improved from 4:52 a.m. last year to 5:24 a.m. this year. However, too many people still begin queuing early in the morning in an attempt to get seen more quickly. 9 facilities still have an average arrival time of before 6 a.m. Of 314 people who arrived before the facility opened, while an improvement from 30% last year, still 90% reported feeling unsafe or very unsafe while waiting for the facility to open. While a circular was issued in May 2019 by the National Department of Health calling on facilities to open by 5 a.m. on weekdays, none of those monitored even opened before 7:30 a.m. Commonly, facility managers tell us that they are unable to extend opening hours due to insufficient staffing to cover this time. Yet, of 613 public healthcare users, 73% think that extended hours would improve access to services. We now move to recorded stories.
Nna ke sebedisa clinic ya Tseki. Jwale ntho e sa nthabiseng ke hore re ema sebaka gate-ing. Re sa kene ka hare ke tsamaya ka maoto a mangata. Ke lata treatment ya HIV fela.
Like they help you and all and you get help, but it's too, how can I tell you, astreerig. So no, I don't go there because I don't feel safe. I don't feel safe. No. I don't feel comfortable like talking to a woman or a man or somebody that knows me, you know. You can't feel open to somebody that you don't feel comfortable with. Like somebody who's like me, more than like me, who can like assist me and guide me and tell me about all these things and all how it works and all. Like people who speak my language. Everybody's speaking Sotho and all that, you know. And it's like English is not my language. I speak Afrikaans, so I feel more comfortable with talking my language. If you are sick, and you want to go to the clinic, you just know that they're not going to help you. Because they have to assist the people that are like, who has dates for their day. They have their people. You have to come the following day. And maybe you're going to get help or not. Sometimes they help you, maybe it's your day, and there are a lot of people. Then you have to like sit there the whole day, you're hungry. And when you're hungry, you're angry. So you just want to wake stand up and go.
sebedisa clinic ena tseki ke nka treatment ya high blood le HIV. Bothata bo ke bo bona nna mane ke ba hore re bua mona re ema ka ntle ka ntle go jalo ke mang pula le ha ena re mo le serame re mo and re tla dula ka nako mo re tlo tswa ka fomo sa lo pitse ka 6 ka 4 gona re tswa mone he jwale le ntona hore re sokola go ha o ile bona le ke ile go dile ke se ke ya gape go di le tlang go go dula o ya go di go di ene a ga sa mamatla mangwele ke yana a o pitla mono ga dula mono o yana o ditse ka tsela go ha o sa tseba go ema jwa batho ba o thuise ba o emise o ya ka ha kana go ngwa ha o ile pidisa wa di o tshwanetse go tlela pe o sa madi ao a dula a latlhe ne ke ile hona jwa ke ntile madi go di pitile a latlhe go tlile ba sa mkhuka madi go ba ga hlole ha ke tlile ya go lo le ke dira motho ke a mo dira tsamaya lo fona nna le ke dira go le bona tseleng ke pinse clinic go ba nka ka re tla tloa mona o tla tloa mona ka seleleng o lo pitsa mane la ta o so tletse mane clinic o tlo khutela hape o sa se batho motho ene ke mo dira mono a lo mfolla o mpata 20 rand taxi yona ke ke go tse
ke le mona harassment ke le committee ya clinic ya harassment re na le bothata bo kopanang le bona ba nurse a shotang like no chelana since from in the morning ho sebetsa manesa a mabedi fela a 2 fela which is kona a permanent batho ba 2 fela and I one o tla a sebetse ka batho ba pregnancy and a sebetse ka bana then o mo a sebetse ka batho ba baholo jwale problem e kopanang le yona haholo holo ke hore batho ba ema nako e telele because ka letsatsi for sure batho ba tsamaya clinic is more than 150 and then ke bothata bo kopanang le bona and o thola gore batho ba dula nako e telele ba bang ba nka di-treatment ba di-chronic illness ba di-sugar diabetes bo di-high blood bo di-TB ba tlo collecta dipilisi tsa bona mane pharmacy ha hona motho a ba thusang ba tsamaya ha ba report anyone like today there is no one who can help the people there manese aya short harassment ke khale le mme wa manager system tsone khale a reporta ba ta hona lexi a thuswa ka yona gore ngwele bo manese mona harassment dinki ba lwane la taba tsa bo di-file tsa bona di-file di a lahleha ha ba thole di-file tsa bona ba bang ba tsamaya without medication go ya high like today hona le o mong o tsamaye o ke for sure o tsamaye le tena le tla be thole dipidisi tsa tsa TB di fedile because the sister ka mela thusa ba ha ka thusa batho a khuta a ka mane ka pharmacy a fana ka dipidisi and how to ka khona ka nnete ha o bothata e ba smetse mona.
There was that one time that I took the condoms from there, and that girl was like the one at the reception. She was like, "Wow, are you gonna sleep with this guy somewhere here or what? Or why are you taking this condom?" Because for me, it's like I always have to protect myself. That's why wherever I see a pack of condoms, I will always take a packet because you never know where the night is gonna end. It's seriously not, a clinic is not a place to want to be, especially at hours. because they doesn't care. They don't care. You can sit a whole day without food. You can sit a whole day without for them calling you. Because at the end of the year, the out clinic, what I used to look up to is like when you give they take your file number, you give them your card, and then they take your file number. They go and take out your file. But what they do is when we put a file in, when they put a file in there by the blood, where you have to test your blood pressure and everything, then the files goes from there to the sister or the doctor. Then they switch it, they put it under. They put it under, especially if you give them trouble during the day, they will put your file under, you will sit there the whole day. That's what I've experienced here at clinic.
We are going to have a few community stories from the people here with us today. Number one, Lerato is coming with a microphone. Number one. What's your number one?
Greetings, my name is Doctor and I'm from Teki Clinic.
So complaining, ekina liona. Kia tshebeletso e slow.
The problem that I have is a slow working conditions.
Ho nese engwe e ya khona ho tloa ka kwa ka mo sebetsa ise ba kudi. E be fihla e tla ho ena ba tlo iqoqa ka mona. Ene batho ka nako eo ba fotse ba emetse ho sebetsa.
At times you'll find that a nurse will leave a consultation room and go to the another consultation room for gossiping with the other nurses, and people are waiting to be helped.
Ho tloa mo no ba tlolla ka hore di nurse di a shota. Empa hana moshadi ho theng ba lekane. Ba dula ba shota selemo se lo ya kwa.
And when if talks, they will tell you that there's a shortage of staff. Always, there's no way that you'll find the staff enough at the facility.
And then liness e sebetsang batho ba mmeleng. O ba tsekisa taba ya hore ba ye soleng empa la ba sena tjhelete ya ho ya hore ba lo shebana ngwana ke ngwanana kapa ke moshimane. Ho tloa mo bana le bothata ba high blood kapa low blood ha ba fe dipidisi nix.
The nurse who works with pregnant women will tell the pregnant women to go to do a sauna, even if one doesn't have the money. And then she will not help by giving the medication to the pregnant woman, whether she has high blood or not.
Dumelang.
Greetings.
Ke tlo bua ka Mofumadi Manapo Hospital, Qwaqwa.
I'm going to talk about Manapo Hospital.
Ke ile ka admitiwa o ke ile ka kena sepetleleng seno ke thotse ka accident.
I was admitted at the hospital because I had a car accident.
Ke fihlile tsatsing lo sepetlele e ne le around past 11 AM.
I arrived at the hospital around 11.
Ho fihleng ha ka mo ha ka ba ka thuswa ke robaditswe fela ke sa fuwa le medication ho fihlela ho seng ka 6 AM ho thwe ke emetse doctor.
Upon my arrival, I didn't get help from the hospital until in the morning around 6 o'clock, whereby they told me that I will wait for the doctor.
Ka nako eno ke ne ntse ke peinela.
By that time, I was in pain.
Okay, thank you.
Ha ke dumedise le nna ke tswa ko tleliniking ya Harrismith. Mathata a clinic ya Harrismith ga gona manese.
Greetings, I'm from Harrismith Clinic. The problem that we have, we don't have nurses.
Ho na le manese a mabedi.
We only have 2 nurses.
E mongwe wa tswa o ya ko mapolasing.
The other one goes out for the farms.
And ha khutla mapolasing e se le late.
When she comes back, it's already late.
Ka nnete ha ona nese ho hang Harrismith ka nnete ho no kopa ho ko fana ka manese. Hobane ha re tsebe na manese a Harrismith a ya kae.
We don't have nurses at Harrismith Clinic, so we are pleading that we receive nurses at the clinic because we don't know where they went.
So hape e nngwe taba ya doctor.
The other issue is about the doctor.
O ya ema o emela doctor o fihlela o kena ka 6 hoseng.
We wait and wait for the doctor until
O
6
dule
a.m.
o emele doctor ha o re 12 ba tlo o jwetsa doctor hatle.
Around 12 o'clock, it's when they will tell you that the doctor is not coming.
Ha wa cha letshare kaofela.
We didn't eat at all.
And it tletse clinic e sebetswang ke batho ba i2.
And the facility is always full. Only 2 people are helping at the facility.
O tloha line e ka mo ntle from 6 o'clock.
From 6 o'clock, from the outside queue, only 2 are
Yeah.
helping.
Another room for maybe 2 hours. O tlohe room e nngwe o tle ka mo o tlo batluwa file.
Then you spend 2 hours in one consultation room. Then when you go to the other one, you're going to spend another 2 hours.
Dihora tse kae?
It's 4 hours.
O tloha mo o ya ka kgolong. Ho na le
Then
e
you
nngwe
go
21
to a hall.
o lo emela nurse.
You wait for a nurse again.
Ha se le tse kae? Se ngata. Ke a leboha. Ka nnete re ne re kopa manese ko Harrismith ga sokola.
We really need nurses at Harrismith Clinic. We are struggling.
Le hore batho ba ka ba mapolasing ba ka ba isetswe moriana hobane koloi ya mapolasing mara ba tletse ka mo.
We also need medication from the mobile trucks or vans because most of the time at the facility, the farm people are the ones who are more at the facility.
Ke tsona ntho tse re di kopang Harrismith le toilet tsa teng ha di sebetse.
We are also pleading with the department that they help again with the toilets because they are not working at
Hlatswa.
Harrismith Clinic.
Ho
It's
clean.
dirty.
Ha leboha.
Dumelang ke Katlego Mafanyolle ke tswa Monontsha Sepedisa clinic ya Monontsha.
Greetings. I'm Katlego from Monontsha and I'm using Monontsha Clinic.
Re na le bothata tleliniking ya Monontsha. Ditlaka tsa rona tleliniking ha di tshware bakudi hantle. Re na le mathata last mona tleliniking mokudi o ile a ba lwantsha nese e nngwe a e shapa e le hore ke mathata a neng a kopana le ona le ena a ska kgona ho itshwara.
We have a problem at Monontsha Clinic with our data clerks. And one day, a patient ended up beating one of the nurses because of the bad attitude.
Hape ke na le bothata ba hore ke ile ka thulwa ke koloi.
I also have a problem because I was hit by a car.
So ha ke ya tleliniking ke lo kopa thuso ya hore tsatsing leo ha ke a kgona ho robala bosiu.
When I go to the facility and explain that I didn't get any sleep a day before coming to the facility.
Ke lo kopa thuso ya hore na ba ka se kgone ho nthusa hobaneng ke mo ke a peinelwa na ke na tjhelete ya hore ke ya sepetlele manabo.
Asking for assistance or any help from them because I'm in pain.
So ba ile ba ntjwetsa se le 3 times ntse ke isa yona pain e tshwanang le eo.
It's 3 times now going to the facility without getting any help.
So be ba re ba ka se kgone ho nthusa hobane ke issue ya sepetlele ha e se ya bona.
And the facility staff explained to me that they won't be able to help me because the issue is with the hospital, not with the clinic.
Le ona mana po mono ho a tshwana. Ha o ile teng molebe ha o fihla o thola file le siko ya loto le lekileng ka le mala ka lona. Molebe ha o fihla o dula ikheletse file ha ona mohla kileng ya tholahala. Ke dula ke na le mathata a tshwanang le ao ene ke affect ya loto tsela pele ho ya pele.
And with the hospital, it's still the same because normally when I go there, my file is always missing or it's locked. So it's still the same. I haven't get any help since.
So re kopa o thusa se believe re thuseng ra kopa. Re thola mathata dipetlele le ditleliniking ke a leboha.
We are asking and pleading that we need to get help from the clinics and also the hospitals.
Okay, next is to support clinic ko Warden.
I'm using to Pilot Clinic at Warden.
Problem ya ka ko re ha ke tsamaye clinic haholo but the day ke ya ne ke sa taba ya hore ke na le bothata ba meno.
And normally I don't go to the facility, but the day I went to the facility, I was having a dental problem.
Ne ke penelwa and ha ke fihla no sna motho a thusang hore ke ye ko kae a nkaedang hore ke tsamaye ke kwa ke nke file kae, and then after that ke tseng tlamle ke lo pompa hore tlamle ke etse jwang.
And I was in pain. There was no one who was helping me or guiding me which consultation room should I go to, and I'm in pain by that time.
Ba qeteletse ba nkenya queuing ya batho ba wrong, and don't tlamle ke leka ema for about 3 hours ke le queuing e wrong.
I ended up queuing with wrong patients, whereby I spent almost 3 hours.
And then ka thola hore tlamle ke ye queuing e ka morao ya batho ba ntshang meno after nako e telele.
And then after the 3 hours, it's when I realized that the queue that I'm in is not the correct one. Then I must go to another queue whereby dental people are queuing there.
By that time, the dentist ne se di tsamaya, so no tlamle ke ye next week because batla once a week go clinicing.
By the time I arrived in the correct queue, I was told that the dentists are already leaving the facility. I must come the following week because they only come once at the facility.
So ne kopa fela clinic organize batho ba kgonang ho guide hore o ye kae, or maybe o thole ticket number ya hore o tlo etsang and o ye kae and o thole thuse kae hantle ka nako.
Can the facility find someone who will help us, or maybe a marshal who will lead us to correct rooms, or rather have tickets to show where to go and how to find the consultation for the dental?
Clinicing ya Mnontsha.
I'm from Mnontsha Clinic.
Clinicing ya Mnontsha re fihla hoseng. Ba bula late.
We arrive in the morning at the facility, but they open late at the facility.
Ha ba bula ba tla be ba nka batho ba ha ba bula ba nka batho ba 10 ha qeta be ba re ba ya lunching.
After opening the facility, they only take 10 people. Then afterwards, they go to lunch.
Ebe ha ba thuse batho ba bang ba latelang.
Then the following people are not getting help.
Ke a leboha.
Naga lebitso ke David Msiwa Mkwena ke dula ko Bethlehem.
My name is David. I stay in Bethlehem.
Ke phaka dipidisi mane Mpohadi tsa tswekere.
I get my medication at Mpohadi for diabetics.
Ke na le hore ha ke ile mono ne ke ya ka 5 hoseng.
When I went to the facility, I always went there at 5 o'clock in the morning.
Ke dule jwale ke tshwarela ene ho ya ka hare.
I will queue.
Ha ke se ke le ka hare ka mono ke pompe he mara ke dule.
After queuing, I'll go inside for my vitals. Still, I'll have to wait.
ke tlo thuseha mane ka bo 3 ya motshehare.
I will only be assisted after 3.
And then ke be se ke tswa ke tsamaya.
Then that's when I'll only leave the facility.
Angibingelele.
Greetings.
Ngisebenzisa ikliniki yase Harrismith.
I use Harrismith Clinic.
Kuyamiwa laphana ekliniki. Isikhathi eside 8 hours uyayihlala ulambile elayinini. Na uzolanda amaphilisi. Uzolanda. Kodwa ushintsha amagumbi maybe 4, 5, 6 ukuze uthole usizo ngendaba yokushoda kwamanesi.
At Harrismith Clinic, you'll wait for a very long time. It even takes you 8 hours to wait just to collect medication. And for that, you'll have to change more than 1 consultation rooms.
Engakuthandanga kwakhona ngelinye ilanga ngangiyekhona ngiyolanda iprep ngalinda ilanga lonke ngingasizakali ngaze ngasizakala le ngabo 4.
What I didn't like there, I waited the whole day just to collect prep, and I was only helped around 4.
Kwaphinda futhi ngelinye ilanga ngathi ngiyakhona ngathola kuqikeziwe kuthathwa yonke medication ekliniki abantu bazolanda imedication yabo bangayithola ngendaba ukuthi ama security awekho.
And what happened again, I went to the facility to collect my medication and the facility was broken into and the whole medication was taken and people who came to collect medication couldn't get their medication.
Namafayili wabantu ayalahleka kakhulu angatholakali. Ngiyabonga.
And the files are missing.
Dumelang.
Greetings.
Ke sebedisa clinic ya Monontsha.
I use Monontsha Clinic.
Ntho ke tlo bua ka yona in affectile because ke motho wa asthma. And most of the time ha ke le clinicing ha ke thole thuso e ke hlokang.
I'm asthmatic and what I'm going to share today, it's affecting me because every time I went to the facility, I don't get help.
It's either habana the medication waka and batlamile ban transfer to either Manapa or Elizabeth Ross.
It's either they don't have my medication or I have to be transferred to Manapa or Elizabeth Ross.
And batlonkanako before that can happen.
And they always take long time before they can do that.
So I lost hope and faith ka clinic ya Monontsha.
Ke lahlehetswe ke tshepo to use the Monontsha Clinic.
Because ke ipotsa hore what if ha ke thole thuso ke le motho wa asthma, what will happen?
I ask myself what would happen since I'm asthmatic if I don't get help.
And they know very well hore batho ba asthma ba sebedisa medication ofeng but ba tlo fa le medication or expired and they'll say hore expiry date hare next.
And they know very well which medication that I must use, and in most cases they will give you expired medication, and when you tell them that you have expired medication, they will tell you that expired medication doesn't do anything.
And Lily receptionist here thing, that girl is very, very rude. Ha a khone hore a bue le motho. O ka etsahala hore o le motho e leng hore o stating sa emergency but wa bo fola.
And the receptionist, the girl who works there, she's very rude and she doesn't know how to speak to people.
O tlo emela file impa case ya hao e tlamehile e regardwe e le emergency.
Even when you are an emergency case, you will have to wait for a very long time for your file.
So ke kopa le etse something ka that clinic.
Please do something for the clinic.
Thank you.
Galebo.
Dumelang. Ke tswa tleliniking ya Monontsha.
Greetings. I use Monontsha Clinic.
Ke na le bothata, ke tlile ka bothata ba batho ba hlabelang for ho thibela peleng.
I came here for family planning.
Ge le re na le bothata ba hore ha re ile moo ha re thuswe ho batluwe dipasa ba bang ba bana ba ile hore ba banyenyana dilemong ba botswa dipotso hore na hobaneng ha ba batla ho hlaba ba le banyenyana.
As a young woman, every time we want to access family planning, we are asked, why are we using the family planning because we are still young?
Ba batla le ho tseba mabaka a hore na hobaneng bana ba ba hlaba ba le banyenyana ha o sa fane ka mabaka a valid ba o kenella ba bue dipuonyana tse seng hantle.
They will always question you and ask you lots of questions to ask you why do you want to use family planning, and if you're not responding, they will start to talk bad and like talk lots of things.
Ke ntho e sa lokang hore ebe ha re ile tleliniking re hloka thuso ebe re botswe dipotso tse ba le hore ha di molaong empa jwalo ka manese ba tseba hore hobaneng bana ba tlameha ho hlaba.
It is said that as young women, when we want to access services at the facilities, we cannot do that.
Ba nyahamisa le ba bang ba bana ba ile hore ba batla ho hlaba ha ba sa batla ho ba le bana empa ka ho ba ha ba sa tlo kgona ho attenda clinic ba tlo etsa hore bana bao ba etse bana ho feta moo.
This, it puts a bad impact that young women cannot go to the facility for family planning, so that is why we are going to experience high rate of teenage pregnancy.
Ke kopa ha re ile tleliniking ya Monontsha re thuswe ho hlaba ha se ntwe ka nkang letshere kaofela ba ntse re dutse tleliniking.
My request is that when we as young women, we go to Monontsha Clinic to access the family planning, may we please be assisted.
Ke a leboha.
Thank you.
Ke sebedisa clinic ya Monontsha. Ke na le di-complain fela ka clinic ya Monontsha ho tloha ho receptionist ha o kena ka attitude a re fang yona ha re kena.
I use Monontsha Clinic. The only complaint that I have is the bad attitude from the receptionist.
O tla nka complain o ise ho facility manager ha o fihla mo le yena o tla ba o fa date hore o tle ka date e so re tlo tla re bua.
You'll take the complaint to the facility manager, and the facility manager will tell you to come back on a certain date so that she can address the issue.
O tla be o tla hape ka date eo e a o fileng yona ha o fihla o tlo bolela hore ke busy e tla ka another date ka nako e so.
You will come on the given date. When you went there, she will tell you that I'm busy today, come again on a certain date.
Ha o fihla hape o fa story seo ke busy kapo e tlo neng nkemele ka ntle hanyane re tla bua up until o fila hore nyane motho ne ka ga ha batle lo ntsheba lo ntsheba.
You go again and the same thing happens, and it feels like this person does not want to talk to me. Oh, she doesn't even want to look at me.
So ra ipotsa hore if facility manager asna nako ya hore a o thusa ka di complaints e bang re na le tsona ka haro clinic ke mo fe motho a temileng a re thusa hape ka mo.
We ask ourselves, if the facility manager does not want to assist us, who is going to help us then to access services?
Again, re na le complain hape ka mme wa cleaner a sebetsang ka haro ho Monontsha.
Again, we have a complaint about the cleaner.
Ha re tsebe hore na cleaner ke cleaner kapo mme o trainer hore ebe professional nurse because kena a fanang ka di instruction ka hare ho clinic.
We don't know if she is a cleaner or a professional nurse because she's the one who's giving instructions.
So ne re kopa hape re utlwisisa hore ho lefapha hore ka nako ya COVID ne re ema ka ntle ho gate. So le hona jwale ho santsane ho engwa ka ntle ho gate. Then re a kopa ho lefapha hore ba ka re bulela clinic then ga kgona ho kena ka hare ho clinic.
So we plea as a community. We understand that during the COVID, we were forced to stay outside the facility. Now that there is no COVID, may we please be allowed to enter the facility? Thank you.
Okay, thank you. But not thank you, because what we heard from the recorded stories and what we hear from the committee members, it is something that is disturbing. My duty is to read the recommendations that are related to this. But before I read the recommendations, I think I need to steal 2 minutes. the other thing which I forgot to mention, colleagues in the room and those who are online, I am also a board member of the Office of the Health Standards Compliance as appointed by the Minister of Health, 12th of February. The duty of that office is to inspect health establishments and enforce compliance on norms and health standards. Every time when I go to the board meetings, I get reports on state of our facilities. It doesn't look good. And it is the same Office of the Health Standards Compliance that must issue certificates for health establishments that are going to qualify for the NHI fund. And I'm asking myself, if our health establishments are in that condition, which facility in South Africa will be able to establish or to implement NHI? Last week we had a meeting with the Free State Provincial Department of Health. The HOD apologized, the DDG was there, and other provincial officials. We were taking them through this report. This is not the first report, colleagues. This is a third report. And I tried to vent my frustrations of meetings like this, of reports like this, because the majority of the things that are reported here, it's not something new. If you were to go to the Ritshidze reports of Free State and read them, compare them to this report, you will realize that almost same things are happening repeatedly. And I'm asking myself, when are the officials going to roll up their sleeves and resolve these issues? Because all the issues that were reported here is actually saying there is a gross violation of human rights. There is a gross violation of the patient's rights. You know, March this year, there was an industrial strike by the healthcare workers' unions. They were striking, toying for salary increase and for that and for that. And as the results of that, their unions met with the government on their demands. And the government agreed on whatever that they demanded. And that on its own made the National Department of Health to have a deficit of about 10 billion rands that they do not have, which they have to spend on compensating healthcare workers. And I'm asking myself, even to this day, I even asked the General Secretary of another union to explain to me what makes them as the unions to demand salary increase if they are not working the entire 8 hours, because we do not understand it. How do they expect us as the public healthcare users to join their struggle when they are disrupting services that are meant for us? They close clinics, they burn tires. When they are done with that, they go to the private health facilities to access healthcare services. I told the Minister of Health, including the board that I serve in, to say, next time when the healthcare workers' unions are having an industrial strike and our clinics are closed and people are unable to get health services, what I will do, I will tell all TAC branches to organize buses and taxis, take all patients to the private hospital, we occupy them. Because they cannot disrupt our services and get away with murder. If next time, comrades, online and here, any union is on strike and clinics are closed, organize and mobilize people, get taxis, go to the nearest private hospital, occupy it, and demand our constitutional right as enshrined in Section 27. Last week, we had a meeting with the Office of the Public Protector, because all these things that are reported here is the violation of the rights of the people. And they wanted us to give them names, but we said, no, we do not want to give them names. One of the problems we have in South Africa, colleagues, on the health budget, a huge chunk of the health budget does not go to purchase health services. A huge chunk of the health budget goes in paying medical legal claims. Billions and billions of rands, they go there. And if our health authorities and duty bearers were able to resolve all the problems that are reported by communities, our department was not going to be forced to pay billions and billions of rands. Somewhere, somehow, heads must roll. Somewhere, somehow, people must be held responsible. I cannot accept it sitting here, listening from that receptionist of Mononsa Clinic being rude to the people as if she or he is making favors for us. This is our constitutional right. We are demanding it. Nobody is making us a favor. And I'm asking myself, what are the managers of that district going to do about that administrator? This is the reason we've got thousands and thousands of people living with HIV who are disengaging on care because they cannot take it. What are you doing, managers, about this? Because if it was me, I was going to dismiss that person on the spot and face the consequences at CCMA. Some of the people who are working in our clinics, they act as if they have made it in life. They act as if they own these clinics. These clinics belongs to us. We are taxpayers. And it's high time now we tell them where to stop. This thing of us as communities, allowing these people to insult and violate our rights must come to an end. We need to sort them. Because if we are not sorting them, the NHI in our country is not going to succeed. Not because of the failures of the politicians, because of the failures of the people hired by our own government. Next year we are going to elections. People are angry. Not angry at the politicians per se, but angry at the officials. The officials are the reason, some of them, they are the reason our government is failing. And someone needs to shake them up until they toe the line. Between 2013 and 2018, as TAC, we have been marching here in Free State, calling for Penny Malakwan as the MEC of Health to be removed. And we are not prepared now as TAC to go back to those strategies of taking it to the streets, occupying offices of district managers, occupying offices of MECs, taking legal steps. We are not on that now. Even though we are no longer taking it onto the streets, we are not getting a commitment from the officials. They always promise that we're going to work together with you in meetings like this. After meetings like this, they close books and forget about us. There will be a stage, colleagues, online, UNAIDS pair for everybody, where we're going to stop what we're doing here and go back to what we do best. Because I cannot accept it that I will always come to these meetings with these fancy reports where we're spending a lot of money, yet there is nothing which is happening on the ground. There is no commitment from the side of the officials. Something must be done. And if we are scared to do it, I am willing to take the lead. Even in Cuba, Fidel Castro started a revolution alone. Others joined him along the way. Even in this case, we cannot keep on having these meetings, yet they are not yielding positive results. We cannot come here and talk about the same thing again. I think the HOD of Free State and the MEC, including the Minister of Health, they must tell us what must we do more. For the past 4 years we have been doing this, but there is no improvement. I am tired of this. I am tired of this. At some point, we need to change the strategy so that we use the language some of the officials and these health providers understand. Here are the recommendations, comrades. 1, we are recommending that the Free State Department of Health should, 1, produce an annual report on the number of healthcare workers per cadre employed in each district, include the number of people and size of areas covered by these healthcare workers. Year-on-year comparisons from at least 2021. We need the vacancies and the cost of these posts to the government. 2, fill all vacancies. In 2023-24 financial year, Extend facility opening times as per the 2019 NDOH circular. Utilize appointment days and times to ease congestion. Ensure filing systems are maintained in an organized manner to reduce lost files. Open clinic grounds by 5 a.m. so that people can wait safely in the morning. Ensure files are not required for facility pickup points. People living with HIV go directly to the pickup points to collect their ART refill. Get more people living with HIV to external pickup points to reduce congestion in our facilities. PEPFAR should, 1, support in filling all vacancies at PEPFAR Operation Putuma support facilities in the short term, provide additional staffing for all PEPFAR supported sites to extend opening hours to 5 a.m. to 7 p.m. on weekdays. Fund adequate numbers of adherence club facilitators to allow for the restart of adherence clubs. Right to care. Immediately do an assessment at all POPs, PEPFAR Operation Putuma support sites with waiting time over 3 hours and develop a specific plan for each facility that will bring the waiting time below 2 hours. Support the facility to organize and maintain an organized filing system. Ensure files are not required for facility pickup points. People living with HIV go directly to the pickup point to collect their ARV treatment. Get more people living with HIV into external pickup points to reduce congestion. I think we are going to hand over to Comrade Unondlela to take us through. Over to you, my leader.
Thank you, Nkoke. The next group of issues are on ARV collection. The revised 2023 National Adherence Guideline, Standard Operating Procedures, note that time constraints are a challenge to many people living with HIV, and that effort should be made to support people living with HIV with suppressed viral loads to receive extended refills and or be enrolled in a repeat prescription strategy. Implementing this is vital to supporting improved long-term adherence. However, Ritshidze data reveals only 3% of people living with HIV interviewed reporting getting 3 to 6 months ART refill this year. This is compared to 22% getting a 3 to 6 months refill last year, and it is well below 64% in Mpumalanga, the best performing province monitored by Ritshidze, and far below the 80% of people living with HIV in 21 other PEPFAR supported countries reported getting 3 to 6 months ART refill in 2021. Thabo Mofutsanyana is the bottom 5 district monitored by Ritshidze on this indicator. Of people living with HIV interviewed by Ritshidze, 51% collected at standard medicine dispensing, with 38% collecting at facility pickup point and only 7% using an external pickup point. Of people interviewed, fewer are using pickup points compared to last year. For those using standard medicine dispensing, 52% said they have not yet been offered the option to use a pickup point. All stable people living with HIV should be offered a range of repeat prescription collection strategy options as per the National Adherence Guidelines. Further, 58% of all people living with HIV interviewed said that they would like to collect ARVs closer to their home if it was possible. There needs to be enough pickup point to decant people into, especially linked to peri-urban and rural clinics. A diversity of external pickup points providers is needed beyond private pharmacy network, largely only available in urban areas. To service rural areas, small CBOs and early childhood development centers should be considered. In terms of adherence clubs, these options have been devastated since the onset of COVID-19. Most clubs have been suspended or reduced of being just a pickup point. We maintain that functional adherence clubs plays an important role in supporting ongoing treatment literacy and peer support to help people living with HIV stay on treatment. Importantly, in order to be effective, repeat prescription collection strategies should make ARV collection quicker, easy, and more satisfactory for people living with HIV. Yet, this is too often not happening. 64% of facilities monitored said that people using facility pickup point must collect files, take vitals, and see a clinical before getting their parcel. 55% of people living with HIV also affirmed this problem that adds to delays at the facility. While it should take less than 30 minutes to collect your parcel and go. 47% of people interviewed said it takes up to an hour, and 24% said it takes up to 2 hours or more. Once enrolled, every effort should be made to keep people continually active. Reassessment should take place at each clinical consultation to understand if people living with HIV are satisfied using their pickup point or club. People living with HIV who are not satisfied or very satisfied, as reported by 33% of people using facility pickup points, should be offered
until they will help me. And it's too long for me to sitting the whole day from 9 o'clock until almost 4 o'clock. Okay, and I have a letter from the hospital. I must only come and collect the medication. Now I'm sitting and waiting for someone to see me, to help me. But they can give the medication there at the pharmacy. But now I must see a sister for what? I'm sitting here 7 hours and wait to someone helping me. And it's too long to sitting the whole day here for only for medication.
Can we please move into community stories?
Dumelang.
Greetings.
Ke tswa ke le Petsana Clinic.
I'm from Petsana Clinic.
Sale ke nwa ARV from 2010 till now.
Since from 2010 taking my ARVs.
So ke tlo kopa lefapha le mpe le re fe treatment ya 6 months hobane ha re no khona ho tla every 2 months clinicing.
My request is that can the Department of Health give us 6 months refill? The 2 months refill is not helping us because we are going after 2 months at the facility.
Because at clinicing ha re kuli, sometimes o kwalla batho ba tleng ka ntho e serious wena o tla fela o tlo collector, so le betere ba re fa 6 months.
We sometimes go to the facility not sick but to collect our medication, and that makes people who are at the facility be inconvenienced because we are flooding the facility.
And then tengwe ya bobedi ne ke tlo kopa hore lefapha le re thuse masi a isetse batho ba baholo dipilisi hae.
My request again is that can the CHW take medication for old people at home?
Hobane o bona le bona ba kwala space ba fihla fela ba tlo collector be le batho ba ba tle ka ntho e serious.
Even the old people are coming to the facility just to flood the facility, and the main issue for them to go to the facilities to collect medication.
And then I qetela boraro ne ke tlo kopa hape hore lefapha le jwetse batho ba o mong le o mong clinic o mosebetsi wa ke eng.
My last request is that can the DOH tell the employees that their description.
Cause rona clinicing ya rona o thola o kene le a professional nurse me a cleaner ke yone o ye meliana ka hare ka mona ha o khone ho ntsha sephiri sa hao ka mona.
Sometimes when going into the consultation rooms, you find a cleaner inside the consultation room with the sister.
Ke a leboha.
Dumelang.
Greetings.
Nna lebitso la ka ke Joyce Malakwane.
I'm Joyce Malakwane.
Ke sebedisa clinic ya Mphahadi.
I'm using Mphahadi Clinic.
Ke phaka ARV.
I'm taking ARVs.
Ke na le bothata ba asthma.
I have asthma.
Ke na le bothata ba mahlo ke bona le haufinyana.
I have eyes problem.
Bothata ba ka ko re na clinicing ba mfa pidisi tsa kgwedi e 1.
My problem is I'm only receiving 1 month refill at the facility.
Kana ko ngwe ha ona motho a mfeletsang ho ya clinicing.
Sometimes I don't have anyone to accompany me to go to the facility.
Ha ke fihla clinicing ba nkomanya kana ko ngwe thola ke fihla ka bo 8:30 ba nkomanya ba mbolele go ke fihla lata.
Sometimes I'll arrive at 8:30 at the facility and they will reprimand me.
Ba mfa komana e 1 ya ARV. Ne ke kopa fela go lefapha le dumelle go ba re fe komane tse tharo bo kgoditse 4 ho ba rona ba bang re na le bothata ba ntho tse ngata.
I only receive 1 month supply. Can the DOH at least give us 3 to 4 months supply?
Skabe ke fetseng ka la bohlano ne ke ile ke lo bona doctor.
Last week Friday I was at the facility to see the doctor
For bothata ba mahlo.
for my eyesight.
Doctor ile a ngolla meriana empa ha ke fihla ka pharmacy ke fuwe meriana e shotang.
The doctor gave me a description, but upon my arrival at the pharmacist, I only received a shortage of medication.
Sister e sebetsang ka pharmacy filing ya ka e tikile go infile meriana kaofela.
And the pharmacist ticked that I received all the medication that the doctor described.
Maobane ke boetse hape ke ya ka doctoreng ke mo bolella go sister o itse o mfile dipidisi kaofela empa o mfile meriana e shotang.
I also went to the facility yesterday to tell the doctor that the pharmacist told me that I received all the medication, but now I can see that the medication is not enough.
And the meriana a sa mfang yona ke meriana e nthusang ka mahlo bane ka nnete bothata ba mahlo ka bo serious bane leihlo le le ka writing ba ile ba letsa operation 2010 ile go ke ile bothata ba mahlo 2008.
And the medication that I did not receive is the medication that really helps me a lot. I did an operation on my right eye.
And jwale le affectile lena le ka lefting ha ke roba le ka nnete ke bothata ba ka bone kopa thuso fela.
And now the right eye affected the left eye, so I'm requesting to get help.
Ke a leboha.
Ke a leboha. Nna ke sebedisa clinic ya Bolata Clinic.
I'm using Bolata Clinic.
Bolata Clinic ha ina taba le batho ba na le mafu a chronic.
Bolata Clinic doesn't care about us chronic patients.
Nna ke sebedisa di ARV.
I'm using ARVs.
Batho ba nkellwang hlohong ke bana ba o thweng ba tle docteng ba nkelwa di number 1.
People that they focus on are the ones that came for the doctor.
Ho tla ba ho be le ba bang ba nkellwang hlohong ho thweng ba se bana ba thweng ba tle ho psychologist ke bona ke ba nkelwa di number 1 le bona.
And the focus will also shift to the ones who are at the facility to access the psychologist.
Bolata Clinic hape e sebetsa ka batho ba tlileng ho tlo pepa.
Bolata Clinic also helps people who are going to give birth.
Batho ba buileng ka bona ba tlo bona psychologist ba tlo bona doctor ke le batho ba tlo pepa ke bona batho ba nkellwang hlong a holo gona batho ba tlo nka di medication ha re nkellwe hlong ho hang ho qalwa ka batho ba o pele gona batho ba lefula mafu ana a di chronic re tla dula clinicing re be re dule.
Pregnant women, people who are going to access psychology are the ones who are important at the facility. As the chronic patients, they don't care about us.
Then ya bobedi ke na le yona ke na ha o ile clinic gore hona le ntho mo collectang remela message o khona lo lata dipidisi go lo lata dintho mo le ka mochining then message ufumana o sa tle o nke bo 5 days o sa khone ho lo thola dipidisi tsa hao because o emetse message hore o fumane pin e lo ntshang dipidisi ka yona neng re se re default ka lebaka la hobane ha re thole gore pin kapa message ha o fihli ka nako mona ntong ho collect dintho tsena tse collectwang.
As a patient who's collecting from the pillar box, sometimes you don't receive any messages or any pins from the pillar box people. But now, because of sometimes you're not receiving that, we end up defaulting because it takes more than 5 days before it can reflect from.
Bothata bo bong ba bolata clinic o ile ka jeno o nkile le tshere ka ofela neng gona re batho ba o ina le dipijo tsa ha o ile ka jeno go tlisetswe hape o sane ho tlotla o qetella dintho tsa ha o sane o sa thuswa next o lo thuswa hape o sane.
The other problem is that the clinic will return you back at home and tell you to come the following day without getting any help.
Re ne re kopa lefapha la bophelo bo botle ka nnete le re utlwele bohloko le re kore le ke le utlwe ditletlebo tsa rona le re hauhele ka nnete ho default o le on treatment of HIV ke molato mo holo haholo o emetse fela message hore o lo collecta dipidisi tsa hao.
Can the DOH have mercy, hear our complaints, and then try to give us help?
Okay, ya o qetela ke ena re ne re kopa Department of Health hore e khutlise ma home based care batho ba ne ba okelwang hae ba kudi ba okelwang hae ha ba sana batho ba supportang batho ba defaulter batho ba na le mental illness go bona hore batho ba se ba tlatla ha ona batho ba hlokomelang ma home based care ba ne ba hlapisa ba kudi hae ba okela hae ba jesetsa hae ha ba sa leyo batho ba no tjena batho ba defaultang ba se ba ngata ho feta ne re kopa Department of Health e sale ho emiswa batho ba ne ba thusa batho ba okela ba ne ba okela ba kudi hae ne re kopa hore Department of Health ka nnete e sekele batho ba ne ba okela batho hae go tlhogela nakong ya pele ba ne ba isetsa le batho ba nang le TB ba support ba khutisetse batho ba hore a kopa.
Can also the DOH extend and hire again the home-based care people, because those people were really helping us, especially the ones who are at home. Can they please return the home-based care?
Ke a leboha ke ditletlebo tsa bolata clinic re tshepa hore jwalo ka Department ya Health le teng sebakeng sena ditletlebo tsa rona di tla sekehelwa tsebe. Ke a leboha.
We believe that the DOH will hear our complaints and they will do something about it.
Dumelang, ke
Greetings.
sebedisa Fatentsentsho clinic.
I'm using Fatentsentsho clinic.
Gona Fatentsentsho ka nnete atjhe ke ba phamisetsa letsoho ba sebetsa ka bokgabane bo botle empa fela ke kopa hore ka nnete ko ba nna ke in ARV.
I would like to give Fatentsentsho a recognition. They're really doing a good job, but the problem is that
ne ke kopa ka re ba ka re keletsa nako
can they extend time
hore ya o lo collecta medication tsa rona 6 months
for us to collect our medication,
For
at least
avoid-
give us 6 months
ho
supply
avoid tshubuhlellano e bang teng clinic.
to avoid overcrowding of the facilities.
Thank you, comrades. I'm gonna read the recommendations. But before I read these recommendations, there is a comrade who was sitting there, but he's outside. His name is Moses Makwamisan. Moses Makwamisan and myself are sitting in the technical working group on differentiated model of care, DMOC, and there are standard operating procedures. Moses and the other colleagues were part of the team that was developing the new ART guidelines. We went on the ground to identify how many facilities have started implementing what is on the SOP of DMOC and the new guidelines. Few of them. And that's why you will see that people are talking about a monthly dispensing of medication as a request. It must not be a request. It's a policy issue. We must demand. Because if it is on the new ART guidelines, it is on the SOP of DMOC, why should we ask for something that is a policy issue? The question we must ask, how is the department planning to train healthcare workers on the new ART guidelines, to train healthcare workers in all facilities on the standard operating procedures? People who are on CCMDD program, when they go to these external pickup points, Akiri guidelines were saying treatment must be there for 7 days. After 7 days, it is returned back to the pharmacy or the hospital, to the depot. The new guidelines are saying the medication must be there for 28 days. Now, what we are caught with as people living with HIV and healthcare users is what is on the policy and what is being practiced on the ground. And the danger of it is when the minister and other political heads are making these announcements, they bring hope to us. And the expectation, when you go to the facility, you expect to see this. It's not happening. Majority of people living with HIV are trained on the new ART guidelines. They are trained on the standard operating procedures of DMOC. Yet, the employees of the department are not yet trained. And when we go there and we start articulating what we know, we are being ridiculed, we are being insulted. But also, I am asking myself, because the other thing which we must address here, it is not true that people living with HIV are community members. We do have people living with HIV within the department, but because they are using private medical they are not known. How were they going to feel if their status was discussed by all those who work in those private hospitals? How do we accept it? A community healthcare worker, a general worker, is distributing medication to people and they end up knowing about their status, because when they go to tavern, that's where they start talking about people and people start defaulting on treatment, because these cleaners and CHWs, they know about the status of the people and people who have defaulted, and people decide to disengage. These are some of the things we think needs to be addressed. The reason today in South Africa, we've got more than, because we do not have 100 facilities. There are more than 100 that are not doing well on retention to care and adherence. It is because of some of the issues that are raised by the community. And if these issues that are raised by the community continue to exist on the ground, we won't get where we want to be. We need to fix the problem within the facility, sensitize the staff in order for us, when we go there, we feel welcomed and appreciated. So, this thing, when people are going to clinics like you, you instead of being given a 3 months refill, you are given 1 month, and you will be told about stock supply and stock this. That is not our problem. That is the problem of the department. And if the department officials do not convene community dialogues, community imbizos, and talk to the users of services, we want to know about these things. Therefore, you cannot make it our problem. That's why it is important, district managers and provincial officials. In each district, you need to have these dialogues with community so that you begin to understand what are the frustrations of your clients on the ground, in order for you, when you come back, you are able to fix the problems with the people that you have hired. The Free State government, Thabo Mofutsanyana district, and all other districts around here, all the 52 districts, and 3,000 and something health establishments that we have in the country, must start implementing the multi-month dispensing of medication. This is a non-negotiable. It's there. All what needs to be done is to put resources together to make sure that what is promised to the people of South Africa is realized. And we can do this, but it's a matter of leadership. If we do not have leadership, we will always experience these problems where now it looks as if we are coming to ask. We are not begging. It is there. And if someone is not doing their job, people must be held accountable, because we are tired, colleagues, of toy-toying. Personally, I'm tired of toy-toying. I'm tired of toy-toying. I'm tired of sit-ins. I'm tired of being arrested for fighting for our rights. But if we are forced to go back there, we are even prepared to lay our lives down in order for the generations to come after us can get better services. But we do not want to go there. It must not be like it is during apartheid time where we were governed by the racist government. We are governed by our own government led by the black people. The expectation is for our people who are in these positions to put themselves into our shoes and stop this thing. When people are appointed in higher positions, they think that they have made it in life. Even in some instances, you will see CHWs that we fought for. When you go to those clinics, they behave like nurses and all what have you, and you begin to ask yourself, these are the people that we slept on the trenches in order for Upeni Malakwane to reinstate them. But now the way they behave to the users of services, it's like they have made it in life. Managers, officials, you need to sensitize the staff so that staff is not the reason for people deciding to disengage. There must be another reason, not the conditions of the facility. Because if the majority of the people decide to disengage, why are you supposed to be paid? What are you doing if there are no people coming to the facility? Some of you will have to be released because the people that you are supposed to be serving or servicing are no longer there. And then we will push for the government to release some of the people. We do not want to go there. Let's work together and save the lives of the people. The recommendation reads as follows. Extend and implement ARV refills 3 months by end of September and 6 months by end of September 2024. If now we can start 3 months refill until end of September, and then by end of September next year, we start now applying 6 month refill, we will see improvement, and majority of our health establishments will not be congested the way they are congested now. Ensure all people living with HIV are offered a range of repeat prescription collection strategy options, and those enrolled in PCR are active. Ensure that reassessment of PCR options takes place at each clinical consultation to ensure people living with HIV remain satisfied with their PCR. Ensure all facilities implement the 2023 adherence guidelines, standard operating procedures with fidelity, including ensuring facility pickup points are a one-stop, very quick ART collection, only visit in under 30 minutes, no need to go to the registry or collect folders, see a clinician. Ensure re-establishment or implementation of quality adherence clubs, including group facilitation component. Increasing the number and type of external pickup points to ensure urban, peri-urban, and rural clinics have external pickup points. Ensuring people going back to clinic for their RPCs rescripts receive the rescripts on the same day, if clinically well, to ensure no unnecessary additional facility visits, with effective recall system to action any abnormal results or alleviated viral load. Monitor and hold accountable district support partners to implement 2023 adherence guidelines, standard operation procedures with fidelity.
Thank you, GS. We are now going to go into the part of the report that speaks about ART continuity. PLHIV lead complicated lives and may well miss appointments and even miss taking some pills. When they do, meeting them with support when they return to the clinic helps ensure long-term adherence, but often when people with HIV and key populations return to the clinic, they are treated badly, leading to people disengaging from care. A differentiated service approach is required for people with HIV who re-engage in care. Some will require intensive clinical management, including advanced HIV screening and management. Some will require psychosocial support in the form of quality counseling and group support options. The majority need it to be made easier to collect treatment. These people should be offered multi-month dispensing and should be assessed and offered access to pickup points or adherence clubs as quickly as possible. Implementing the 2023 re-engagement clinical and adherence guidelines are vital to support adherence and retention. Right to Care should support the remaining 55% of facilities and all others in the district in training, mentoring, on changes in the new 2023 adherence SOPs. Ritshidze data reveals that of 615 respondents, only 59% of people thought that there was always friendly and professional staff at the facilities. Thabo Mofutsanyana in particular was in the bottom quarter of districts on this indicator. 41% of people did still think that the staff were only sometimes or never friendly this year, while down from 52% last year. This still needs to be urgently improved upon. This graph shows data across time since data collection began in the district. The district should continue to improve to ensure that all people living with HIV, key populations, and other public healthcare users are treated with dignity, respect, compassion at all times. It is also important to note that because Ritshidze interviews took place at the facility, people who have already disengaged from care were not reached. Some have disengaged due to poor staff attitudes, some of who we will hear from in community stories would not be at the facility to interview when we collected the data. The best and worst performing sites are outlined in the tables as shown. Out of 78 people living with HIV who had missed appointments, positively 73% said that the staff was welcoming when they came back to collect ARVs if they had previously missed a visit. 22% said that the staff still sends you at the back of the queue the next time you came into the facility. Yet, according to the South African National Welcome Back Campaign Strategy and the National Adherence Guidelines, people should not be sent to the back of the queue or made to wait until the end of the day to be seen. A returning patient should either be seen in a separate stream or take up the next queue space. Further, the 2023 Adherence Guidelines SOP says returning or re-engaging patients should not be made to wait until last to be seen by a service provider, but should join the queue on the same basis as all other patients. No punitive actions may be taken by the facility staff. While most people did not report transfer letters being a challenge, 184 people interviewed by Ritshidze had been denied access to services for not having a transfer letter across 5 facilities over the last year. While this just represents 7% of public healthcare users interviewed in the district, given that most people interviewed are unlikely to have attempted to transfer services, it continues to point to a much larger problem according to the communication and policies regarding transfer letters. This is a reminder that transfer letters are not required in the guiding principles of the re-engagement SOP, which states, if a patient comes from a different facility, it is critical that the patient be provided with treatment on the day of presentation. While referral letters are helpful, a patient cannot be required to leave the facility without their treatment. 294 people interviewed by Ritshidze had been denied access to services for not having an identity document across 9 facilities over the last year, representing 13% of all people interviewed. All sites should be urgently investigated. Again, it is important to note that Ritshidze interviews take place at the facility. Therefore, people who have already disengaged from care due to challenges accessing a transfer letter or an identity document would not be at the facility for us to interview. Psychosocial support is another critical element to ensure long-term retention. Yet, Ritshidze data shows that only 46% of people living with HIV interviewed do not know that psychosocial support is available. Further, a full package of psychosocial services are not yet available at every clinic. A full package of services should include provision of individualized quality assured counseling to patients, peer-led patient navigators acting as a bridge between clinicians and patients, mapped networks of referral services, optional support groups, and food parcels. As part of psychosocial support, support groups should also be linked to each public healthcare facility, and that is critical to provide counseling and support services to people prior to testing, post-testing, pre-treatment, and those struggling on treatment or re-engaging in care after a treatment interruption. Treatment literacy also improves ART continuity as people understand the importance of starting and remaining on treatment effectively. Of the 283 people living with HIV surveyed, 81% had received a viral load test in the last year, yet only 74% had reported that they knew their viral load. There also remains a significant gap in knowledge and treatment literacy. Only 77% agreed with the statement having an undetectable viral load means that the treatment is working well, and only 67% agreed with the statement having an undetectable viral load means that the person cannot transmit HIV. No facilities had perfect scores where all people living with HIV understand why an undetectable viral load is good for their health. At some, very few, PLHIV understood that an undetectable viral load is good for your own health. No facilities had a perfect score where people live with HIV understood why an undetectable viral load is good for ensuring you cannot transmit HIV. At most, far fewer people live with HIV understood that an undetectable viral load means you cannot transmit HIV. Only 48% of people living with HIV at Putadichaba Clinic understood, and only 56% at Tseki Clinic, for an example. This highlights that the message that an undetectable viral load prevents transmission, the U equals to U messaging, still needs to be better communicated. We are going to move to recorded stories.
Ke tsamaya tleliniki Bethlehem Bohlokong. Ke tsamaya ke nka dipidisi ka mora 6 months. Ka mora 6 months ha ke kgutlela tleliniking ke thola mathata a hore ke thole file tsa ka di lahlehile. Ke tlo ema tleliniking mo go fihlela ka nako tsa bo 4. Ke kgutlisetswe hae. Ha ke kgutlisetswe hae ke tle ka letsatsi le latelang. Ha ke fihla hape ne ke thole bona bothata bono. Ke tsamaile tleliniki nako e telele ebile no tjena na ebile ke kgathetse. Ke la ba ka e tlohela. Ha ke se o tloba njetsa hore madi a ka a jwang. Ha ba ke be ba njetse. Le bo sister ba ba ka monna ha ba hantle. Hoba ke batho ba dilang ba omana. Ha o a bua ba omana. Nako o thola bo doctor ya lekgowa. Ha ke a bana sekolong. Ha ke a kena sekolo. Mara neng ha o ba hlalosetsa ba ya omana hore ba kgone ho hlalosetsa hore doctor e reng. O tetelletse so sa tsebe hore doctor itseng a e khona. Ho ntse se hantle. Ho fihlela lena la ka jenne. Nako e tlameleng hore ba o thuse ba o botsa pele hore o nkile pap smear ha o tjha wa nka ba o jetsa hore o ye o nka pap smear la e ka bono se ikemisetsa ho nka pap smear o tlo ya bitsela hore ha ba tlo kgona hore o thuse.
Oh, nna ke tsamaya tleliniki ya Boiketlo. So ke qadile o tsa ho nka treatment ya ka 2020 clinicing eo ya Biketlo ke tsamayang yona ba re fa dipidisi di-container tse pedi ho etsetsa hore mohlolomong ho be le kgwedi e re fetisang re sa ye clinicing. So a sa le ba ntse ba re fa ho tloha selemo sena se qala up until now ba nkile madi but ha ne ke ile ka di-19 no manta ha hona ha ba mpolella niks ka taba hore di results di kgutlile di re eng ba mfile fela medication. So nka be ke kgutla ka ne nka thabela ha batho ba ko ba sebeletsi ba clinic e ka re mohlomong ka bona le bo ma social worker mo clinicing be ba nyolo go ba utlwella dilo tsa go hobane re le batho re ya mo clinicing ha ke hane re kula empa re na le mathata a fetang o ya mono wala wa tsoa go ba la sa ja treatment sometimes ha wa sebedisa yo tshwara ka tsela e seng right. So then ha o ntsha maikutlo a hao ho manese mohlolomong kapa ba ba sebeletsi ba clinic kore ho bona ha ba etle e le point into e tla fela le taba rona mona ha re ke no rona mosebetsi wa rona kudu go thusa fela ka taba medication then fela mo so re end up re nya so nna ke nana o ka ba better ha o ka bana le mohlomong mokgatlo kapa ma social worker ka bante ho utlwella dilo tsa batho ba banyolo ba sokola ke sona fela sello sa ka se.
So ke tsamaya clinicing ya Ritshidze ke tsamaya clinicing ya Ritshidze go di nngwe le nngwe ke leta treatment ya HIV. So for nna side like treatment ko ya dinese ha sha for because ke nako go di nngwe le nngwe ha ke clinicing ya Ritshidze ke qabana le bo sister ha ba ntlhalosetsa even today ibile ba tshintshile mo tjena hona le tse ding tse ba mfileng tsona and I didn't hantle ke dinwa ka timetable ke tshong hape le ka itumela gore e nwa treatment ke e nwa hape le ka sa dumele okay dipidisi treatment ba mfa yona ha ba ntlhalosetsa gore ke mofuta mo wa dipidisi ke tseba fela gore ke dipidisi tse sebetsanang le ke le gore ke na le lona philo ke tlo phela lona full time ke tshong ke mix ke komana tse two ka komaneng e nngwe e kgolo ke nka tse two ka komaneng yana ke nka le wena mara ke dinwa ka nako le wena o tshweng ke dinwa o seng le mantsibu ke tsamaya clinic ke re kgwedi le kgwedi mara ha ke ile kgweding ha one ke fuwa treatment komana eo ya kgwedi fela ha ke lo nka madi o tshweng ke a nka madi sometimes ba njoetsa sometimes ba njoetsa since ke skopa speed sa treatment ke nwa ha ke so arabue ntho e loreng e hlakile hore se a tholahala kapo ha se tholahale.
Ke tsamaya clinic ka ya ba ke dipaka ke lata di ARV tsa ka mo so clinic e bula ka 7:30 e ba e bula ka 7:30 ga go thosetse e go e bula ka 7:30 mo lete mara tshebeletso ya teng ha ke nna ha ke kgotsofala hobane mo le ba rile mo fihla o se ka bo 6 o tsamaya ka 4 o khutle hape o sa thuso ho thu di sister di ho sa gape o khutla wa dula khutla hape ka 4 ga le ba o thusa ha le ha o thusa ha go ke ntwe o ka ha 3 days o tswa clinic o tlo di sister di o se sa sister tse pedi ke ga le disi ka mo le ke dinka DDI ke dinka khoditse pedi ka ba khoditse pedi hape ke khudela mami clinic ke go madi clinic ba jetso ka mora ka dikana ke khutse ke tlo ka mani ke tlo utlwa result bo nnete ke ya fihla ba jetso result tsa bo nnete tsa tsona dilo di ha ke ba tlo tlasha thole nna khono ya tsatsile ha o ya ho sa ba jetso o dule o emela batho ba go fela ba tlo thusa ga fo ha ba kwa ela na fona hana o fihle se o dula fihla ga fo ba o lo file clinic o dule mo fihla ga fo le ha o thusa ha go ke ntwe e etsahala clinic e ka mo e ke tsamayang ke thabela hore ho be le go ba e ke di sister di bete go batho ba kgona ho thola ba kgona ho thusela go ba le go khutla le bangata bohlaena ha o le ha o ya clinic batho ba sa thusahala go tloga le bangata gape o sane o le bane ba date eo ya go sane ga go thusahala o utlwa ga kopele le bangata batho ba o kopile batho ba khopile pele tsa bona di bohloko batho ba sa thusahala o nna ka di-sister fela ga go sa jewe sister tse dingwe go kgona go thusaga le setšhaba
ke dula mona Bethlehem ke sebedisa tleliniki ya Baken Parka nke be ke sebedisa Mphwadi ke bona e le sephethephethe haholo so mane Baken Parka ke a thusahala teng ke kopa le tlhomphano gona ba kutse re tlhomphe bomme ba go thusang gobane le bomme ba go thusa le bona ba buile gona hantle ga re fitlhile o seng tleliniki e sebetse ka nako ga o itswe 7:30 appointment e le 8 ka 8 o qalo o sebetsa o se ka thoka 8 be le kgona go tlhekwang re eme ka ntle a se le re fitlha o seng tleliniking re eme ka ntle tleliniking ke lo lata treatment ya ka ke motho wa lefu la HIV ke se ke yana tjena se ke lata DDI se ke ya tleliniking ke lo hula madi fela ke kopa ke ya tleliniking ke thole tshebediso e hantle
tleliniking e ya Petsana ke tla mona ke tlo ka treatment ya ka ya HIV tswekere so go na le motho a sebetsang like receptioneng mono ngwanenyana o sa le monyane dilemong and ha re thaka sa hae then 6 months e fitileng ngwanenyana eo ha bua le nna a sebetsang mo receptioneng ke fitlhile ke bia ya karete mo as usual re rutwe jwalo then ka dula fatshe se le hole ke a bona ba batho ke ba latelang ka morao ba tlang ka moraka ba ntse ba feta ke ya ke re ke beile karete monana ngwananyana ha a so ntšhiki jwalo a ntšwetsa gore yena karete a e arabellang ke yona ye a itshwereng e le gore re tlamehile gore le tlamehile bo arabile hantle a re ha re sa di beya fela dikarete ke la ka mtshepisa thupo ga ke tlo be la gating ko tsholo wa hae go dile go ga ka fase bo nkgono bala ba thaba ba wa tla wa kgalemella ngwanenyana yona ha re bone ka next wa re chika go fihlela ha kana mpule ke tleliniki re mara heka ha re bo sister ha ke batho ba qalla leshano ba ntshita sharp
Colleagues, before we move, can we listen to each other, colleagues? Thank you. Before we move to stories, we've got Umama, Provincial Chief Director for Strategic Health Programs. She's got another meeting that she has to rush to, and she asked that we give her a few minutes before she leaves. And if we remember, she was here earlier so that she can have enough time with us. But unfortunately, we had to start late because of unforeseen circumstances. So let's allow Umama from the provincial department to talk to us and reason with us. Over to you, Ma'am.
Thank you, Chair Anelen. Dumelang setjhaba sa heso. Good day to colleagues on the line that are listening. Like he has indicated, I have another engagement. Unfortunately, I have two. But my colleagues in the district, who I think will have more answers than myself, will be engaging with you. However, from where I was sitting, I felt very much uncomfortable. From the stories that I see on the reports and the stories that I hear from our users, I am very much uncomfortable and disturbed, and I don't know, I can go on and on and on and on to show my dissatisfaction. Ke tlo bua ka Sesotho le nkutlwe. Re na le ntho e bitswang hore ke ministerial injunction. Di tsheletse. Hara tsona, ho na le e buang ka staff attitude. Yo, story tse ke di utlwileng ke staff attitude. Ho tloha ka tlelaka, you ho fihlella ka nurse ka nnete ya swabisa. Hona le ho tsona di ministerial injunction, hona le e ho buang ka waiting times. And then be ke le kuka ke lisa ho ntho e buti yanelang tsa bua ka yone, your constitutional right to health care services. We have complaint management system mo health. Ha so re o etsetsa favor ha ke tlo render, it's a must. I must render you a service. We are being appointed to do that. Whereas the professionals are taking an oath. Hore ke tla sebeletsa setjhaba sena sa heso, I miss meno na mebedi ya ikana. They are not doing you a favor. You've got that right. And if you are not comfortable with that right, ba. Di teng di clinic mo tshwantse hona le di box tse go kinywang lo tsenya lebitso name and shame hore re lokise dintho. If you don't do that, re tla dula ntse re ho generalize is not going to assist us, because even if there are some people like kwale ko patents ho builong hore there are some people that are rendering good services, we are demoralizing them if we are going to generalize. But if we are going to be specific and say Ramudula ungwakile, then the district must deal with Ramudula. If the district doesn't deal with the Ramudula, then the province will come and deal with the district. That's the only way you can correct the system. Guys, it's the time for us to stop complaining. Go to hukum. It's time for us to be vocal when we want to correct this government of us. We are fortunate there are people who are looking for jobs outside with better qualifications, better, well-mannered people. And they're unfortunate they cannot get, but we were blessed to get the jobs. Then, we must correct it. And at the same time, let's put them in that box so that at least we develop the morale, and maybe they might change. There's a booking system, but the district will explain better, because I'm just looking at what we usually decide upon, and we say the implement you. So the district will talk more to this booking system. However, if a person atla anale pain, razeba ina toze accident, o atla ona le pain, re mo bolella ka hore a ye kwa tshwantse a ikise teng. What happened to the referral system? You'll talk to that. Eye care system, eye care services. I sense me was supposed to be referred. Or what you call it, outreach. But the specialist should have seen in me, because but I don't hear where she's talking, she was referred to a specialist. Melena, because I sense it's an orthopedic case. But in general, the referral system should be implemented. And it's not a booking time, because you don't know the reason of my headache. I might get a stroke because I'm having a rise in high blood. So guys, the youth zones, I feel, pain. We said our facility should be youth friendly, where the youth are supposed to be assisted so that they don't waste time. Now, if you are going to ask them questions when you are supposed to be uploading and acknowledging that you have come here to prevent unwanted pregnancy, that will lead to this person not going to school in future or having it to break, have a gap. And again, having to take care of the child that is not wanted. What are we saying about our future? The society that is going to be created by those children. Guys, listen, I'm just giving hints, and I want to, when you go to your clinics, these are the things that you should talk to when you talk to your personnel. Yes, we understand we have a shortage of staff. The director is indeed the analysis, and the analysis was presented to our principals. Currently, our principals are looking into how best we can appoint, especially the nurses. Infrastructure like the toilets that Matt talked to, Sahiri Smith, and the waiting time where Mayor on the intro was talking to say when they go to the clinic, I forgot to know that clinic, but I'm sure she noted. Ha ba ile mo ba ema kantle, whether rainy, dusty, or what. What are we saying about a person's dignity? Are we not complicating these people? So I'll refer this to the infrastructure, because infrastructure has a list, they call it B5, where they are going to attend to facilities, but I'll bring them under the attention of the infrastructure so that we see whether is it amongst them. I'll talk to the colleagues here. The role of community health care workers and, clarity of job of whoever. I know of something that is called confidentiality, and the professionals are told about confidentiality. And I get a sense that in those facilities, there's no confidentiality when it comes to patients. When they deliver the medication is supposed to be in a closed package, because it's for the patient, not for the person who's delivering the medication. Get the difference. It's for the patient, because the patient had conversation with a health professional. And then the health professional decided to say, based on your symptoms and signs, this is what you need. And then when they take it to the patient, it's supposed to be covered. It's supposed to be in a package. I think the issue of the implementation of the SOP, you'll talk to that. How far is the training? And the issue also of support, psychosocial support. I know that we are busy appointing social workers to strengthen support and adherence, because we're not doing well with children remaining unarmed because of caregivers and parents that are not being supported, and the very children. So I know that we are strengthening that. We are busy filling those posts. However, we still have the social workers that can provide psychological support, even the psychologists, when it's needed. Because some of the clients have not adjusted or something happened and they will need that support. So please, let's ensure that they get those supports. This must go to the people at the clinics. It mustn't end here. It must go to them because it's them who are doing these things that the community is talking about. It must reach them. On that note, I think I covered those things that I wanted. They made me uncomfortable. I hope I'll drive safe where I'm going, because really, but I'm relying on you to go to those clinics and talk to those nurses and whoever is in that clinic, and we'll do the unannounced. On that note, thank you very much. Eh. Ke yona ntho e ke buileng ka yona, I'm sure ntate ha o utlwa. Ha? Di a lotlelwa, but mme o tla bua ka yona. Di a lotlelwa, but mme o tla bua ka yona. And then ha di sa lotlelwe le teng, ke santse ke tsholo, o na le right ya hore o bo ikshutele photo o complain ka yona. And remember, complaining high fail clinic house as satisfied. It can go even to the presidency. On that note, I would love to have stayed with you, but because of other engagement. But I think I've heard enough. Thank you very much.
Thank you, Mama. Siabonga, we thank you. We will be left with other officials, and we will continue with the meeting. And we appreciate your comments, your commitment, and how you engaged with us. But moving forward now, since you have mentioned that it's like we are generalizing, I think what is important now is for community members, for us to ask community members to identify the name tags. But in some instances, you find out other nurses are not putting name tags, but we will report that so that we name and shame. And because from where we are seated, not all facilities are like this. Not all healthcare workers are doing like this. It's like a rotten potato within a bag, which must be isolated. So that's why we are going to name and shame. But the other worry that we have, when we name and shame, people will be disciplined, they will be dismissed. It will take 2 years for the department to fill in those vacancies. Or else the vacancy will be created by the dismissal of this official in this clinic, and that position will be opened in another clinic, and that particular clinic ends up suffering, and people will be like, if you had not reported that nurse was going to be there. But we are going to report, we are going to name and shame. And also, as we said in our meeting, that we are going to convene a follow-up meeting with the HOD and the MEC so that we can agree ukuthi within us as Ritshidze, TAC and the PLHIV sector, who will be sitting in the Operation Putuma meetings at provincial level in all districts, but also we want people who will be sitting at facility level in order for us to be able to address some other issues immediately. But also, Section 42 of the National Health Act talks about the health governance structures like your clinic committees, hospital boards, and the Act gives powers to the MEC to appoint them, or the MEC delegates someone. And if we go to on the ground, clinic committees are dysfunctional. Those that exist, they don't know their mandate, they are not supported. In order for them to have meetings, a facility manager is the one who must call a meeting. If clinic committees were functional and they knew what their mandate is, some of the things that are reported by the community could have been resolved in those clinics. And we had an agreement with the previous MEC that she's gonna use powers vested in her according to the Act to appoint Ritshidze, TAC, PHIV sector members in all the clinic committees where we have branches, but that never yielded positive results, because if we are to deploy right people who are the users of care, they know their mandate and they will be able to hold other clinic committee members as well as OPMs accountable for not delivering the mandate, because the issue of the complaint suggestion box that is being opened, it's a reality. And clinic committee members, they do not know that they represent the community. They go and open those complaint box, ban those complaints, and not give a feedback to the people. But if clinic committees can be trained and be resourced, it will be easy for them to carry their mandate. Without wasting any time, we're going back to the program. Siyabonga Mama Nyambe kakuhle. uThixo onesekelele.
The issue of naming and shaming, not all disciplines. There are others who are online. Okay. Not all the misconducts will result in dismissals. We are trying to build behavior, good behavior, and ensure that patients, clients, our customers get quality service. Will not just dismiss immediately. There's a process. Thank you.
Skala Thaba. Nyambe kahle mama. Over to you, Mary.
Thank you, GS. We are going to go into the community stories.
Dumelang.
Greetings.
Ke tswa Petsana Clinic. Ke ne ke sebetsa mapolasing.
I use Petsana Clinic and I used to work at the farms.
Ke mo clinicing Petsana ke lata dipidisi tsa HIV.
I collect my ARVs at Petsana Clinic.
Jwale ne le hore ha ne ke ya clinicing ne ke thola le hore ka nako nngwe ba nkatisa nako e telele ke a matsatsi a 2 le hore jwale ha ke thole day me ke sebetsang teng.
My problem is that when I went to the facility to collect my ARVs, I normally spend 2 days and I don't get off days where I work.
Ke ne ke na le selemo ke se ke sa dine dipidisi.
It's been a year now that I stopped taking my ARVs.
Ke a leboha.
Thank you.
Dumelang.
Greetings.
Bitsa ka Petsana ke tsama clinic ya Petsana.
I use Petsana Clinic.
A bo sister ba Petsana ba re tshwara hantle ho.
The sisters at Petsana Clinic, they are very rude.
Ke ya tsama ke ba jwetsa ke ka mo ha ke na maoto, ha ke na monwana ya maoto. Ka mo ke na monwana kaofela ka mo ke na monwana e 3. Ya ga sister ke kopa hantle go nong ke tsa dietana. Ora ke tla bukela doctor. On fa date a se ke mo botsa sister la ke tloaneng doctor a ga ke manager ha ke a manager ga ndwetsa go ya now busy and make dulang teng ke dula hola le clinic nne ba mfa date ya about 15 ha ga kgwedi and ha ke na ngwana sebetsa ke gola pe ha o lo fle clinic ba qetela ka we le gore ha ke na tšhelete o pala moya o ya mo.
I survive on pension grant and I don't work And I explained to the sisters that I don't have toes, and I requested for boots, and they normally gave me the dates, but every time they gave me a date, it's normally on the 15th, and I don't have children who are working, and I don't have money to go to the facility. Thank you.
Dumelang.
Greetings.
Nna ke sebedisa clinic ya Putaichaba.
I use Putaichaba Clinic.
Clinic ya Putaichaba re fihla hoseng ka bo 5 re fole ka ntle. Ha re fotse ka ntle ka moo ka nako e ba tlo bula ka 7:30 re kena ka hare. Ha re kena ka hare ka moo re santsane re lo sokola hore re thole di file.
Morning, and when they open at 7:30, that's the only time when we'll be allowed. And we always struggle for our file, and when we get our file, that's when we'll go and collect.
Jole ha re fihla ka moo ai ke teng me re lo dula.
And when we are at the place where to collect the medication, it's where we are still going to wait.
Wa thola batho ba sebetsa mo clinic ba na le batho ba ba tsebang mo clinic ba latela di file ka hare rona e le khale re fihlile mo ba fetele file tsa bona mo rona re tla tswa ka mo ka clinic ka bo ma 2-3 ke hlokomela gore clinic ya Putaichaba tlamile o bana le motho mo tsebang a sebetsang clinic ba ha o sena motho mo tsebang o tlo dia ho thola treatment ha o tlo tloa mo clinic ka bo 2 e le go fihlile ka 5 o se.
The people who work at first, because you'll find out that you came early, but you'll still be sitting there, and they will only go inside to collect the files from the ones that they know.
Engwe hape ke ena ya clinic ya Putaichaba ke na le 8 years ke phaka treatment.
It's been 8 years that I've been on ARVs.
Ha ke so ka kutlhalosetswa hore na ha ke nkile madi di results tsa ka na di reng. Ke bolellwa fela hore o ntse gutlela collect and go ke sa tsebe hore na di results tsa ka di reng. Ke a leboha.
I will always go and take blood, and they will never explain to me. They will only tell me that you will have to go and take. Thank you.
Dumelang. Ke sebedisa clinic ya Putaichaba.
Greetings. I use Putaichaba Clinic.
Ka di 28 ke la ka tswa holo ha ke elellwa o ne ke ile ke lo nka madi ke la ka tswa holo ha ke elellwa gore na ha ke na di results ho tloa 2018.
On the 28th, I went there for my blood, and I was so shocked to find out that I don't have results since 2018.
And a menese unanza ele o shebile mo no file nyaka a thola gore na o ntse o pesha di pesha tsenana tse ha o nka madi tse pesha mo file maganeng di results ha diyo.
And the nurse found out that there are stickers in my files, but the stickers did not have my results.
Ke la ka ukwa bohloko haholo bane ke le tjena ha ke tsebe CD4 count ya ka ye me jwang ha ke tsebe nix.
It pains me a lot because as I'm talking now, I do not know my CD4 count. I don't know anything.
Ke a leboha.
Thank you.
Yes. We are now going to head into
the last one.
Okay. It seems like we have the last person.
Dumelang.
Greetings.
Na ke tswa Petsana Clinic. Petsana Clinic ha ya tloa e nsebeditse hantle ho hang. Cause ke la ka kenelo ya re ha ke kenelwa ka tliswa phekulong. Ha ke tliswa phekulong monana ya be ke ya testuwa he ka thola go thwe ke positive. Ya ha ba founela ba mpotsa ke tsa Petsana Clinic ke tsa clinic u ka ba se ka ke tsa Petsana Clinic.
I use Petsana Clinic, and it happened that somebody broke into my house, and I was brought to Pekulong, and when I got there, I was tested, and the result came back positive.
Then ha ba founela Petsana Clinic ba ba botsa hore ke testile ning. Petsana Clinic ya re nna ke defaultile.
And when they called Petsana Clinic to find answers when the last time I had tested, Petsana Clinic told them that I am a defaultee.
Ka nako eo ha ke so ka ba ke nka dipidisi ho hang.
And I've never taken treatment.
Ya re ha ke fihla Petsana clinic ke ba botsa hore nna ke default ho tloa neng.
I went at the facility and demanded questions like I asked them, when did I default?
Yabe ba re file ka ilahlile ke sa ba kopa kopang dihloho.
I was told that my file is missing.
Ene o tloa ka nako ne ke le bohloko cause ba ngotse ntho eo filing ya ka e bang ke tlo tsamaya case ka yona ba bule maka ka nna ba sa double check.
You can understand that at times I was so angry and I wanted to go and open a file, a case, so because they have told a lie that I've defaulted and I was never on treatment.
Ke a leboha.
Thank you.
All right, thank you. We are going to have recommendations by the GS.
Thank you. We are going to the recommendations. You know, Mary, on the 7th of September, I am invited to a meeting in Pretoria. One of the agencies that is funded by PEPFA is going to have a meeting with their district support partners. And I'm going to that meeting with a positive mind because I want PEPFA and CDC to tell me and us, what are these people that they are giving money from PEPFA doing in our clinics? These district support partners. If we, the comrade who was giving testimony there, was taken by us as a community back to care. And there are many of them through these engagements that we are doing at community level that we are returning back to care. It is against that reason we are asking district managers to inform facility managers that ours is all about saving lives, and if we can work together, we can assist in bringing many people back to care. But those who are given money by PEPFA and their agencies, they must tell us what are they doing with this money given to them by PEPFA. If we're gonna have lot of problems like this, which are happening in front of their eyes, yet they don't see them. Because some of our colleagues, even if they are a community members, when they are hired to do a particular work in a facility, they turn their mindset and think that they are the nurses and forget that their mandate is different from the mandate of the nurses. That's why in some facilities you find the cleaners telling people who have defaulted, you find the cleaners giving people medication and files and all that stuff. This must be corrected. But also, as I've said before, that our reports are not about finding faults. But unfortunately, on the side of the department, improvements or progress on issues that we are raising are not shared with us in order for us to be able to include those areas of improvement to our reports. And if this was shared with us, our reports were not going to look like one-sided, because one will justify and say our reports are one-sided. Yes, we are the servants of the people, but it will be good if the department can share with us improvement in some areas so that our reports can always tell the good and the bad. And also there is this issue about transfer letters. It is a serious problem. And hospital, when Dr. Aaron Motsoaledi was introducing the NHI pilot project, among other things that he said he wants to address through the NHI pilot project is a unique patient identifier. I fail to understand. I am using ABSA Bank. Wherever in South Africa, I can go to any apps and withdraw my money. But we are unable to do that within the health department. We were told about these big words, unique patient identifier, biometrics. And if people had all these things were in place, people were not going to be turned away. Others are saying to us, the reason are denying people treatment who do not have transfer letters, it's because of the Nyawope boys. We do not know what is that, which is a lie. It is a lie. But people, they just don't want to do their job, and they don't want to give people life-saving treatment. I am asking myself that a piece of paper can make me to deny a person a right to life because a person does not have a transfer letter. Does it mean that person must go back home empty-handed without a treatment, subjecting that person to die? Which rights are we talking about when we are denying people their constitutional right? And if health is a fundamental human right, what are the steps that facilities are taking to mitigate in terms of these challenges? On the recommendations, 1, ensure the Department of Health staff acknowledge that it is normal to miss appointments and or have treatment interruptions. People living with HIV returning to care after a late or missed schedule visit with open arms. Ensure Department of Health staff treat people in a dignified and a friendly manner and investigate any reports of poor attitudes raised by Ritshidze and take disciplinary actions where appropriate. Send communication to all sites highlighting that no person living with HIV should be sent to the back of the queue if they miss an appointment, as per the Welcome Back campaign strategy that says people returning to care should be triaged. Ensure transfer letters are not being required for ARV continuation or restart. Any reports where treatment is delayed by requirement of a transfer letter should be urgently investigated and disciplinary actions taken where appropriate. Implement the 2023 adherence guidelines, standard operating procedures with fidelity, including ensuring every person starting ART is provided with good quality fast track initiation, counseling session 1 at ART start and session 2 after 1 month of ART. Taking first viral load as early as possible to ensure providing earlier adherence interruption support and earlier access to longer treatment supply at more convenient locations. Actioning an elevated viral load without delay, including funding and setting up effective abnormal results recall system and providing quality enhanced adherence counseling when appropriate. Action a suppressed viral load without delay, focusing on immediate assessment, offer and enrollment into the repeat prescription collection strategy of choice the month after viral load is taken. All facilities implement 2023 re-engagement algorithm, including appropriately differentiating services for returning people living with HIV. Ensure Department of Health and Right to Care staff provide accurate and easily understandable information on treatment literacy and adherence, and the importance of an undetectable viral load through consultations, counseling, and outreach. Ensure that treatment literacy information is provided at health talks each day at the clinic. Ensure that the Department of Health and Right to Care staff explain viral load test results to all people living with HIV properly in a timely manner. Ensure Right to Care staff acknowledge that it is normal to miss appointments and or have treatment interruption. People living with HIV returning to care after a late or missed scheduled visit, silent transfer from another facility or treatment interruption should be welcomed. Ensure Right to Care staff treat people in a dignified and friendly manner and investigate any reports of poor attitudes raised by Ritshidze and take disciplinary actions where appropriate. Support with training and mentoring of DOH staff at facility level on the revised 2023 re-engagement, clinical and adherence guidelines, standard operating procedures. Fund an expansion of people living with HIV and key population-led treatment literacy efforts across all provinces through training, education, and localized social mobilization campaigns. I thank you.
Thank you, GS. Comrade Tato is going to take us through the key population segment.
The next group of issues are those affecting key populations. Public health facilities are the entry point for many key populations into the health system. Therefore, it is critical to ensure a friendly, respectful, safe, and confidential environment for all, with services that cater to key population-specific needs. Yet, despite sensitization, training, and retraining efforts, disrespect, ill treatment, and dehumanization of key populations remain a widespread challenge. Key populations who are treated badly, humiliated, fear their safety, or even refused entry will inevitably not come back to the facility. Ritshidze data reveal that at public health facilities, only 58% of gay, bisexual, and other men who have sex with men, 41% of people who use drugs, 73% of sex workers, and 50% of trans people reported staff are always friendly and professional, where the attitudes of clinic staff have become unbearable. Some people have stopped going to the facility altogether, including for HIV, TB, and STI screening and treatment. Clinical staff were again this year the most commonly reported as being unfriendly and unprofessional by all key population groups, followed by security staff. Overall, people who use drugs face the most unfriendly services across key population groups. The majority of key populations interviewed do not feel safe or comfortable at the facility. In order for services, spaces are needed that feel safe, comfortable, and private enough to disclose you are a member of a key population group without fear of judgment, abuse, harassment, or even arrest. Disgraceful privacy violations continue to occur that destroy people's rights to privacy. 46% of gay, bisexual, and other men who have sex with men, 20% of people who use drugs, 11% of sex workers, and 17% of trans people do not think privacy is well respected at clinics in Thabo Mofutsanyana. Where key populations do continue to suffer the daily indignities of using the public health system, specific services remain unavailable for the most part. Ritshidze data reveals that a low proportion of facilities provide services for key populations when asked generally. Just 2 facilities reported providing services for each population group. However, when asked for the specifics of which services they provide, it is apparent that very few KP-specific services are in fact offered. 8 of the facilities monitored in the district do not report offering any services for any key population groups. Key populations can't always access basic prevention tools like condoms and especially lubricants. The Free State Department of Health made positive commitments last year that condoms and lubricants would be made available in all Free State public health facilities going forward. We note that there has been some improvement on this. This year, 71% of facilities say they provide lubricants for HIV prevention. However, while up from 25% last year, lubricants were observed as being available in only 32% of facilities monitored. Additionally, lubricants need to be put in places that people can take them without being judged, embarrassed, or even outed as a key population group. However, in most sites, lubricants were only available in the main waiting area or by reception or by request in consultation rooms. When we spoke to key populations themselves, only 67% of gay, bisexual, and other men who have sex with men interviewed, 0% of people who use drugs, 59% of sex workers, and 75% of trans people using public healthcare facilities said they could access lubricants. It is important to note that this key population data was gathered during the time that the department was implementing this commitment, and as such may well have improved in this year's round of key population data collection. The department should continue to improve to ensure all facilities provide lubricants for HIV prevention, actually make lubricants available to collect and put them in private and easy to find spaces across the facility. Again, the department made positive commitments last year to make PrEP available to all key populations at all sites in the province. However, compared to other districts in the province, few facilities prioritize offering key populations PrEP, despite it being available in most facilities monitored by Ritshidze. While covering a wider and differing set of sites, only 19% of gay, bisexual, and other men who have sex with men, 5% of people who use drugs, 5% of sex workers, and 17% of trans people interviewed reported being offered PrEP at the facility, pointing to the reality that while PrEP is sitting in facilities, key populations are not always made aware of and actually offered PrEP. Again, it is important to note that this key population data was gathered during the time that the department was implementing this commitment, and as such, may well have improved on this year's round of key population data collection. The department should continue pushing so that all sites actively offer PrEP to key populations. Key populations are at times refused access to contraceptives, specifically because they are a member of a key population group, as reported by 33% of people who use drugs interviewed. South Africa faces a well-documented epidemic of gender-based violence, including homophobic and transphobic attacks. Sex workers also face extreme levels of violence and forced sex at the hands of clients, partners, and even police. It is critical that key populations who face sexual violence feel safe enough to access the necessary services at the clinic, such as HIV testing and post-exposure prophylaxis, STI treatment, emergency contraceptive, J88 forms, rape kits, counseling, and referral to domestic violence shelters. However, only 27% of gay, bisexual, and other men who have sex with men, 40% of sex workers, and 67% of trans people thought staff were well trained to care for those who have experienced sexual violence. Widespread access to harm reduction services remain outside the reach of most of the people they are meant to serve. Those who have tried to access harm reduction services are often left without services or any information where they could get them. Only 5% of people who use drugs were offered information about where they could get new needles. Only 7% were given information on where to get methadone, and only 6% able to access drug-dependent support. Service accessibility must be improved to ensure that people who use drugs' needs are met and no additional barriers are created to being able to take drugs safely or be supported to stop. The availability of gender-affirming care services for those who need them is critically important, yet only 67% of trans people say facility staff are always respectful of their gender identity. 33% say that healthcare providers use their wrong names, and 33% said they use their wrong pronouns. 67% of trans people we spoke to wanted to access hormone therapy at public health facilities. However, hormones are mostly only available in big cities. Trans people who do not live near these cities must travel long distances to get these services. This keeps it out of reach for those without access to transport money and places to stay. It is positive that PEPFAR and the department have committed to establish one center of excellence per district. However, one site is just not enough in districts that are vast, and these sites will not be providing a full package of services or hiring new staff that are sensitized to the needs of key populations. We urge the department and PEPFAR to at least establish 2 sites per population group per district, where a minimum package of KP-specific services are made available, and to hire KP-friendly staff so that these facilities are highly sensitized to the needs of key populations and provide friendly, safe, and confidential services. Move to recorded stories.
Ke na le 28 years ke dula Ritshidze ke tsama clinic Ritshidze ke dumela ka mokgwa ba re thusang go ne batho ba tsuba especially go ne batho ba tsuba ba re treata ke na le medical group ka ya a ke phaka medical group ka nene ka di tse ba re file a re fitla di ntho tsa rona re nthuli ke package tsa rona re nthuli nene a tsa ya nna ba blima nna because ke a tsuba ka poketsa ba yebo ba don't treat that because a ya tla kana ko itse ke tle ka yona ha ile bona ba phoso ha ba treat be a di business ko ke mo ba mfa ntho di tya usane ha po ke closane ya fitwa sane ba mfa peace peace ke di nwang ke tsa kgwedi ke clinic kgwedi ba mfa peace tsa kgwedi fe le madi ke ngaka selemo se seng se se January ke nka madi ya nene wena bona ke no check wena aba hlalesetse before wena o di batla.
I identify as a trans woman. I live here around Qwaqwa at Bulkambush. I attend the Bulkambush clinic. I take my antidepressants there and my sleeping pills there. Really, the services that I want from the clinic is the HRT hormones. Yeah, because I'm a trans woman. I want to change. I want to feel like a female. I want to feel like a woman. I want to look like one because I'm a trans woman. And what I can say about what I don't like about the clinic is that I think maybe they like information about like us as trans people. Because I remember the first time when I wanted to actually take HRT hormones, I went to Manapa Hospital. I was actually referred by a nurse from the Bulkambush clinic, and she told me like to go to Manapa for an appointment. She booked me an appointment, and then I went to see the psychologist and the doctor there. They actually told me that I can't actually. It's a long list. There's a lot of candidates actually who want the full procedure. So yeah. So I think that was back in 2019. Then I went back to the clinic. I didn't actually go back to the clinic because I go every year. The thing is, there was this other nurse who was like, aren't you interested in like HRT hormones and stuff? And I was like, I am interested. And what she was like was, there's actually a doctor here who does consultations like this, because there used to be a person we used to do the very same thing for them that you want. And I actually went there for consultation, and I was told that I can't actually get access to HRT hormones at the clinic because they actually have no info about that. They don't do that at the clinic. But I was told that I was going to be like referred to a specialist clinic that actually deals with all that. Thing is, I don't want to say, I don't want to blame them and say like, because there was like, we're going to give you a call so that you know when is the appointment for you to actually go see them, to see the doctors there at the specialist clinic. So thing is, I lost my SIM card, but they actually gave me another appointment so that I can see the doctor, so that she can actually do the referral letter again, and so what I really don't like is that there's no actually services for us as transgender people at the local clinics. Yeah, that's what I don't like about the clinic. The treatment that I'm receiving from this clinic, my antidepressants and actually...
Especially for matters pertaining to sexual health screenings, etc. It's not it's not yet a comfortable experience because of the people that man the facilities, in the manner in which they treat queer people with the stories that I've heard. It like makes it very hard, provided the nature of the information you need to give in order to get the help that you really need. I'm not really comfortable going to the clinic for that reason. For me, it's very important to have people like me in the room who would understand. So I would be a lot more comfortable not talking to an old woman who's from a different generation, or an old man with, their religious convictions, because it's one of the things that I imposed on us in the clinic. Like, usually when they open in the morning, we have to start with a prayer, for example. So that alone creates a barrier when you have to share certain things, because it makes you quite aware of their religious convictions from the beginning, and there's negativity that comes with being queer from a religious or Christian point of view.
Ke sebedisa kliniki ya Putebcha. Batho ba kliniki ha o ya ho bona o ba jwetsa hore ho etsahalang ka wena. Ha tlametse ba o thuse, ba tlo betsa hore o kolo dulela kwana masaeteng hanyane. Ha ba fihla bo locationeng ba tlo bua ka wena hore o bone kae kliniking, ba o kgotlisa, ba o dudisa botulong. And o go ha ile jalo o tlo utlwa bohloko le wena. Jalo ka mang le mang, ba ska nna ba re mang a ye kae.
Ngiphuma e-ARVs meeting ikliniki engibuya kuyo engiyijwayele ukuya kuyo iNtabazo clinic. Nginokufika ngiyolanda ama-prep, condoms, lubricants, and then bangitshela ukuthi after 3 months I have to come back ngizobuya ngizothatha amapilisi. Sometimes bayabuza ukuthi why nilalana nabafana, why nenza into ezinjalo, because niyazi ukuthi uNkulunkulu waletha abantu ababili emhlabeni. Be like, awu wena umsebenzi wakho ukuthi unginike into right engizoyenza la. Bese kangenzela nezenzo acting, bese ka-acte ukuthi Stefan nasoke. Be like, sengiyasaba kuya nesikliniki nehlangana estradini. Be like, ama-prem, i-lubricant, i-condom kuhlezi bakubeke etafuleni lapho, noma ungene ngesithathela ufake isikhwameni sakho uhambe abakubuzi. Ihlezi ingcolile, ama-toilet angcolile, amanzi sometimes awekho, windows kustinking, kustampi nje, kuhlangahlangene ngaphandle nje, akuklinwa. But yona ke i-province indawo erayi kwamele ihlezi inakekelwe umasipala, but nje nayo ithulile akayenzi next.
Nna ke dula Putebcha motho maqheku ke sebedisa kliniki ya Putebcha. Ha ke a mo kisa ke a ka o isa ngwana le lo testa gore ke negative kapa ke positive na. Ke na le motse 18 tshwana 18 ka November this year. Treatment ya mo kliniking sometimes ya ba re tshware sharp because ona batho ba judgmental mo. Like how ke se ngwana ba re botsa gore nana why o na le ngwana le mnyane tjena ba nthina tse ba. Okay, so the condom ba di ba pela reception ha o kena fela mna condom mona na tlametse o dinke so nna ke sa ba o dinka cause kwa batho ba tlo jaja go sebedisa condom le mnyane tjena. Nna mosebetsi o ko etsa ha ke kgone hore ke ba jwetse hore ke sebetsa mosebetsi o tjena na for ba tlo jaja hape. Ba bona motho a private a kgonang ho like ba re yona nna ke motho no go tlo ba le batho I ba experience di feelings tsa bona mo kliniking mo then ke ska nna ka tshaba ya thinking ke lo testa cause ke la le nka bo selimo ke sa test ka pa bodi kgwedi ke tshaba thu ya gore ha ke je testa ba tlo mpotsa so ke tlo testa hape go bala le batho ba bangata.
We are going to move into our community stories with community members that have joined us today. Yeah. Yeah, please. I don't know. Yes, take this one. Oh, thank you. Yeah. It's too late.
Dumelang. Nna ke moahi wa Petsana Ritshidze, ke tsamaya Petsana Ritshidze clinic. So then nna ke motho a recover from the drugs, from crystal meth. Ne ke tsuba yona. So then now ke pregnant.
I'm using Petsana Clinic as a resident of Petsana, and I'm a drug recovery, and I'm pregnant.
So then checks I got in Petsana clinic here fit la senka bo 6 just kana ko ba re betseng yona re kene ka hare so then ba tlo qala sebetsa ka 10 AM.
What I don't like about the facility is that we arrive at 6 o'clock, and then they will only start giving us services around 10 o'clock.
So then sister na ya iketla, but anyway now I iketla mara o etsa mosebetsi wa hae o motlo o makgethe. E tla be ke leshana ka ga itse mosebetsi o makgethe ena. So then text I got in ka di cleaners ba tla o jaja sister o tla o jitsa gore no wa recover o sharp, but me wa cleanang yo ka mo sentse o botsa o no tsubela eng a o jaje o tla mo a tlo holetsa o dutse setulong a ba tlo o jitsa hela matrax ema wa bitswa. So then ntweno ha ke rate o hang cause ke la qeteletse ke quick enga ke mbotsa gore o ngena phi a go tla tlo njaja ka gore it doesn't matter what's my background naga kapa eng go ke tle jwang go ke be pregnant ne ka tana bongela ha sta ba high. So then turn I enter because ha ke mbona mhlale ke atlalelana lo tswa late happy clinic.
Then so what happened was that I didn't appreciate was the treatment that I've received from the cleaner in the facility, because the nurses, I won't lie, they help me very well. They're slow, but they do give me services, complete services that I'm happy with. But the cleaner comes to us, or comes to me in particular, and calls out my name, referring to me as the druggie, to respond to being called by the nurse. And she goes as far as telling other people in the facility how much of a drug user I was, and asking me questions about why did I begin using from the first place. And I don't like that. It has now gotten me to a point where whenever I see her, I'm already angry even before she starts saying anything. I would like to be assisted with that situation, because if we are not helped with that issue, it won't end well between myself and herself, because there was to a point where she asked me how I felt pregnant as a person who's dating other women. So can I please get assistance with that? Okay, thank you. We are now going to move into the recommendations.
Thank you, Mary. We colleagues, we're gonna move with the speed of how trained, because time is against us. But I think before I go to the recommendations, in South Africa we've got a constitution that was amended by Rolf Meyer and Cyril Ramaphosa as they were mandated by Nelson Mandela. There, in that constitution, there is a Bill of Rights, where, amongst other things, it gives us rights as people of South Africa, that we've got a freedom of choice. And it can't be true that I will enforce my beliefs to someone else in a process of trying to convince those people to think otherwise. That is not what government hired people for. If government wanted to hire social workers, they were going to hire social workers. And now in some facilities, you find out that some health providers are tending to be social workers or religious people preaching their beliefs inside the facility. But also, this issue of Petsana Clinic and the other facility where cleaners are disclosing status of people, I so wish, like now, we are not generalizing. Petsana Clinic, general work, and if the department wants names, a comrade can give names, and the other comrade can give names, so that we can see the commitment from the side of the department. We are not saying dismiss the person. What we expect is for the person to be engaged And if possible, the person to come to the comrades and apologize to other people, because it is evident she is not the only one. There are many people who are insulted by a mere cleaner, calling people druggy and all what have you. Maybe that cleaner has family members who are on drugs, but they are not doing the same to them. If we're talking about dignity and the rights of the people, we need to see action being taken. I will be glad if maybe we come again having meetings to hear Comrade Nondlela, Comrade Zozwana, Comrade Jodi, to hear what has happened with the case of a comrade who was stigmatized and discriminated by a general worker, and calling her and other people with all sort of names, because that is not acceptable and we cannot tolerate that. So the recommendations, colleagues, are as follows. Ensure that all clinical and non-clinical staff, including security guards across public health facilities, are sensitized on provision of key population-friendly services to ensure a welcoming and safe environment for all key populations at all times. Key populations must be involved in the implementation of these training modules. Any reports of poor staff attitude, privacy violation, verbal or physical abuse or harassment and or of services being restricted or refused should be urgently investigated. Expand the Center of Excellence model to ensure that at least 2 public health facilities per population in Thabo Mofutsanyana serves as key population designated service delivery centers. A minimum package of services should be made available at these facilities as outlined in the State of Health report. Easy referral and adequate resources, including transport money for transport, must be provided for people to take up these services. PEPFAR must support these facilities with additional key population-friendly staff and resources to provide comprehensive health services to the specific key population being served. Ensure that HIV prevention tools, including lubricants, external and internal condoms, PrEP and PEP, are made easily available at all public health facilities in Thabo Mofutsanyana. Make available external and internal condoms as well as lubricant in a range of space across the facility, e.g. waiting areas, toilets, gate, pharmacy, consultation rooms, quiet areas, out of sight, so people can freely and easily collect them. Ensure that PrEP is offered to everyone, including key populations who are not living with HIV or who test negative for HIV, with information shared on its benefits. Ensure no staff members ever tell key population to use Vaseline or other oil-based lubricant instead of water or silicone-based loops. Over to you, Mary.
Ngiyabonga Kokhela. We are going to discuss now infrastructure and cleanliness and other clinic conditions. The country's load shedding crisis negatively impacts the provision of healthcare in our clinics and can often lead to people waiting much longer to collect medicines or consult with a clinician. In Thabo Mofutsanyana, the most common challenges include data capturers not being able to capture information, creating a backlog, and impacting follow-up with people who have missed appointments and recall systems, and delays in finding the files when filing rooms are in darkness. Generators at each facility could resolve these challenges, yet no facility is reported having a generator that is working or has fuel. 18% of facilities monitored in Thabo Mofutsanyana were observed to be in a good condition, up from 13% last year. The most common reasons for poor clinic conditions were to do with lack of lighting and broken or cracked roof, walls, or floors. 82% of facilities reported needing more space, down from an 88% last year, with waiting space and filing space given as the most common things facilities needed extra space for, impacting negatively on congestion, TB infection control, and maintaining an organized filing system. And overall cleanliness, only 53% of public healthcare users reported that health facilities were very clean or clean. However, 13% reported that facilities were dirty or very dirty. Wow. 73% of Ritshidze observations found that toilets were in bad conditions with no toilet paper and no soap given as the most common reasons, with a substantial number that were dirty. We are going to have recorded stories, forgive me for that.
Nna ke nka treatment ya ka tleliniking ya Tseki Thajaneng ke sebedisa collector di ARV mo. Bothata ba ka ke bona ha re fihla mo tleliniking mo go thola ke tleliniki e tshwatu jela ga tseng ka ba bankile di medication tse nka phoetsa lana ke ka dula mo nene ile ga le re dutse to thola nako ngo dula bo 30 minutes bo hour ba bona hour tse pedi ya tse tharo ba go dutse mo a ke go plamela go ba tlo go tsa ba police station ha ba khutla mo nana na go setsa mail o tshotse ba ga tse ka ba tla ba go tsa gona ne treatment ya gona ha iyo but ba shedona a inkile wa khutla ke go khutlela hae ya na ke batla go tseba go bona gona ke plan B ife ba ka yetsa mo clinic ba nsela hangata ke go le sela 5 ka past 6 container e connected to le clinic ya hona le masoba ka ntena ka ntwe ha ke se ka po le lokala mo la hlosheng e ka ntena ka tso tsena di kenal ka mo di nyulo di kena ka mo ka di ceiling ha o sana ceiling clinic ya rona ha right ha ke ga ke lo nka madi no tsana ke ile ke ka mme ba nkile komana tse tharo bottle tse tharo sa mati ha ke ka gast ke sa tswa date ke tlabe ba tla ba mpha feedback ya ka hona le batho ba a ke tseba ithaopi bana ba re tsheka di result bona ba fa di result ka pampiri o ya ka tsona ka ba kenya file ba mpile komana tse tharo tsa di PDC se ke tloya ka hostess ya ne di ntshwere le hantle tsona bothata fela ke eng fela tleliniki ya rona ha e kgasise
ke tsamaya tleliniki Bethlehem bohlokong hobaneng nakong ba thola ba ituletse bona mo ho thwe ke load shedding and load shedding e sa tswa fihla hana jwale mara nna ke tsamaile tleliniki ka kgola bo 1980 something ke ntse ke phaka ARV mara a icon ho no ntse se hantle ho fihlela lena la ka jenne
la Bukambushi tleliniki e ke tsamaya tleliniki ya Putsa Ditshaba tleliniki mo ke ya mo ke a etsa ha ke ba ke ka di prep ke ha ke tswa se mhlamhlena cause of line ne ke a tswa ke a mono ke na ha no go tlo ka pele mara neng o bona le bo load shedding ebe ga kholose ga sokola ke la bona line e di ya tsamaya ke tswa go say ka bo ma 5 ka bo ma 10 11
We are going to move into the community stories. All right, thank you. There are no community stories that we have in the room, so we're going to go straight into the recommendations by the GS.
Thank you. The recommendations are as follows. Ensure that all public health facilities have a functional generator with sufficient fuel so that health services and administrative work can continue during load shedding. Ensure that all public health care users are consulted, tested, and or cancelled in private rooms. Carry out an audit of all facilities to assess infrastructural challenges, after which the department should develop a plan in order to renovate building and ensure adequate space to provide efficient, private, and safe healthcare services. The department must establish the audit results. Hi, this one, Pago OHC, we are dealing with this one. We are going to penalize now health establishments that are not compliant. They are going to pay money. We are pushing that. In the interim, provide temporary structures and ensure that more people living with HIV are being decanted out of the facility and receiving longer ART refills to reduce the burden on overcrowded clinics. Ensure that all facilities are maintained to the highest standards of cleanliness, including through implementing regular cleaning rosters. Ensure clinics have resources to provide soap and toilet paper in all the toilets.
Thank you, GS. The next set of issues is going to cover tuberculosis.
The next group of issues are on TB infection control. In South Africa, around 300,000 people develop tuberculosis every year and about 56,000 people die. Yet, TB infection control in our public healthcare facilities remain inadequate. By following a simple checklist of good practice, including key measures that were successfully implemented during COVID-19, facilities can be safer for public healthcare users and staff. With the checklist in mind, Ritshidze has developed a scorecard and a traffic light system to rate clinics on how good their TB infection control is. Clinics that adhere to all the measures are given a green light. Those that are on right track but still off target get a yellow light. And a red light is given to those that are way off the market on ticking the checklist for the 6 measures. In April and May 2023, 0 facilities were awarded green status for checking all 6 measures on the scorecard, and 0 clinics yellow status for following about half of the best practice measures for infection control. All 11 facilities surveyed failed altogether at meeting the 6 basic best practice to stop the spread of TB.
Thank you. So the recommendations are as follows. Issue communication to all facilities stating that 1A, all windows must be kept open. TB infection control posters must be displayed in visible places in the waiting area. C, public healthcare users must be screened for TB symptoms upon arrival. D, people coughing or with TB symptoms must be seen first to reduce the risk of transmission. E, people coughing or with TB symptoms must be provided with mask. F, people who are coughing must be separated from those who are not while waiting. Carry out a full audit of all public health facilities in the province to assess TB infection control based upon World Health Organization guidelines, after which the department should develop a plan based that to improve TB infection control. The department must publish the audit results. That brings us to the end of the first segment. Now, we are left with less than 15 minutes before we finish. There are organizations that are here, which is Treatment Action Campaign, Sanarela, and NAPO. provincial leaders of these organizations that makes who Ritshidze is. What I'm going, and also with also the right to care people are not here. We are communicating with them on emails. They are promising that they will be in welcome with vets, and the provincial department has already commended. So we will give 2 minutes each of these 3 organizations, and then the rest of the remaining minutes we will give to the district management team of Thabo Mofutsanyana to comment and respond to some issues, and then after that we are going to close. So we're gonna start with a comrade from Napwa to come forward. It's not me, comrade, it's the program. We will welcome the comrade from Napwa to come forward and say 1 or 2 words. I do not know whether we're going to share the mic. Oh, you've got the mic. It's off.
Dumelang. I am in Kaplaluna Kekarabo Msia from Napwa. Kito it's an input ka key population. Key population ki eng. Key population ki batho ba at higher risk of being infected with HIV. Like batho lo re ke MSM, transgender, gay men, sex workers, people who inject drugs, and people in prisons. These people, when they arrive at the facility, they get treatment as in sharp. But then the healthcare workers, they are lebala hore. Without the people, there's no work. With the people, there is work. They should bear that in mind. So how much ado treata motho hampe ha le siwa ha no gola. So tlamile ba offer the service right, the lubricants, hormone pills, condoms, and everything that the key populations need. But then with the little work that you are doing, Department of Health, we really appreciate it.
Thank you, comrade. We're gonna call upon Pastor Lindani Saliwe from Sanarela. Over to you, my lead. There is the mic behind you.
All right. Good afternoon, ladies and gentlemen. My name is Lindani Saliwe. I'm a pastor. I am a community and medical chaplain. Ditikiwe mfana nawe. Nanditikwe ndogqibela ba ngihlale ngigqothe emsebenzini ngenxa yokutoyitoyela abantu abangaphathwa kakuhle kwi-facility. Ndichongiswe izinto ezimbini ezintathu, just to be quick. One of them ile izenqo apha kum. We cannot be having people who are scared to go to the facility because of us pastors. We cannot be having people who are defaulting and running away from the treatment because of what we are preaching. The facilities, the department has a policy now of trained chaplains to go to the facilities, who knows what to do, what to say, how to do things. The people who are going to be spiritual carers of our people in the communities. The people abayazi indobana, we are different in spirituality, we are different in religion. Abakwaziyo ukba, we have boundaries and we have laws in South Africa. And other people have rights in South Africa. And we cannot be having okanye sikhala ngento enye each and every day yokuba abantu abaphathwa kakuhle kwi-facilities. That sidilishe nayo in the past. We cannot be dealing with it even today. The department have to do something about it. And one of the things, the last one, in your recommendations, GS, about indaba ye-TB, I think the TB should be treated as COVID. The way COVID is treated ngayo. If only TB ingatreatwa ngaloo ndlela, we'll be able to reduce abantu ababa infected each and every day with COVID. The safest place in the clinic, abantu abayoyikayo kakhulu, it is the room apho kutreatwa khona TB. People don't know that is the safest place, but outside kulapho kuyingozi khona. Abantu bafuna ufaka mask if befika ngaphakathi. Now I'm talking to you. Bafuna ufaka mask if befika ngaphakathi kule room apho bayo consultwa khona. Whereas that is the safest room if you didn't know. But upper phandle, you are sitting with a lot of people whom you do not know. If by infected or not infected, that is the most dangerous place. Kulapho fanele khona ube uhlala ufake mask wakho. I think sizoqha into benifuna ukuzithetha ezo sihlam.
Thank you, my leader. We will call upon a treatment action campaign. Comrade Maina Mokoena. Over to you, Maina.
Thank you, leadership. And na ke na ntho ngata ke bua. Ne ke kopa fela ho keta pele ya ka ituletseng ka pele e ntle e kgabane. Hore ka nnete ke bohloko ka jeno. Ha ke na le mantswe gore le motho ne ke tlo e bo e fedile. Clinic tsa rona e ka re re iseditswe batho ba sa trainwang ha ke sheba. Ka nako nngwe la ha o ile o re ke tlo thola thuso mona ba tlo gona go ba cancel ha ke bua le bona. Go thola motho na anka train na a isa kwana. O tswe mona o utlwile bohloko bo fetang boneng bo utlisitse. O kena clinicing o sa kule haholo. Mara o tlo tswa mona o kula haholo ka baka la maemo wa bonang. La isese ka wena. Ka motho a tla ba dutse pela hao kapa. E ka re ba re sheba rona wena o hlapile ha kae. Wena o ditshilenyana ho lo kae. Gore clinic tsa rona go bua nnete e go re tlhoka training e serious a ditlamaniseng a rona ba ile ka hore na wena o mang ke o tseba ho lo kae o tla ba o bitsa ka ga clinic ka lebitso ba o jwetsa ka mokgwa ba batla nka ba ile mole ba sa re ba lo sebetsa ba ile mole ba le go bontsha gore na bona ke bo mang monyako wa clinic o tla bula o kwalo topo e tla lla e kwana ba lebetse gore re a lapa bona ba tla ba lunching ba ya tieng ha bana hane le bakudi bana ba ka mona go motho ona la tlonka treatment e batla hore a ba jile nako o tlo nka le tshegelana na kaofela a saja o la tamang treatment ene ha tlemene hore a e jelle ha o ditse clinic tshegelana kaofela wena o ntse o ja nna ke saje ho reng ho wena ha ke ba bua tsengata ke le ba ke tapele yaka.
Thank you, Comrade Maina. Now, the department has been listening to us. We are going to afford an opportunity to the Thabo Mofutsanyana district management team. We do not know how is the arrangement, but the floor is yours. The floor is yours, ma'am. Over to you, ma'am.
Sorry, thank you, leadership. I am Mekilani. I'm the local area manager for Malutia Pofu. Let me appreciate this forum that is here. That as much as we have received so many issues that are not what we are expecting of our services, some of the issues are an eye-opening that says Department of Health, wake up and implement all the guidelines. And let me raise the issue that I am now aware that there are some guidelines that we need to go back as Department of Health and retrain our staff because we receive new employees frequently. So let me just indicate that we are going to go back and look at ourselves where we are going wrong. Let me also raise an issue here that has been said about the community dialogues. as an important platform where we are going to share with our community about the issues that affect health and the issues also that affects the new strategies that the department is putting in place. I want to indicate that really we need to go back and talk to our communities, because some of the issues that talks to the booking system, it says we are not reaching the community the way we are supposed to reach the community, and the community dialogues are going to assist us to reach the communities. If I may respond to some of the issues that has been raised. The issue of staff attitude, I think Ramodula has already talked to staff attitude. I'm here with some of the OPMs from the facilities that have been named here. I think definitely they are going to go back to their staff. I wanted to talk about the issue of, the first one was the issue of queuing outside. I've seen 2 of my facilities have been mentioned that the clients are still standing outside as if there's still COVID. I think we have addressed this issue, and the facilities are having policies that guide us now. We have changed from wait lines to stand in a queue outside. We need to address those issues. Let me also raise that our facilities are not enough in structure also to allow everybody to come into the facility in the morning. But the department is working on that, because there was a request of us to choose facilities where we see that the space is short. It's less for the community that is being provided with services. I think something is going to be done as indicated. And then the issue of, the second issue, okay, with the issue of queuing outside, the facilities knows that they need to implement the infection control policies, where if there's somebody who's coughing, they need to be given a mask. So that should be implemented. We are no more going to let the clients stay outside. Thank you. And then the second issue that I wanted to raise, the issue of delay of messages. That is very critical. Let me just indicate that in case there's a delay of a message to reach a person is allowed to go to the facility to indicate that there is a delay, so that the facility manager or the staff in the facility would call then CCMDD and find out the reason why there is delay of messages coming through. And then the other issue that I want to address is the issue of the new art guidelines. I have also attended the training that is being rolled out now. Malute Apofung, 2 trainings have already been done. This week they are in Mantsopa. It's true, the training of a new guideline where the clients are going to be issued with 3 months treatment was delayed within the department, but it has already been rolled out. We are expecting that around October we'll have done 80% of the staff would have been trained in the new ART guidelines. Already, we are already starting with trying to increase the procurement of medicine, ordering of medicine to issue as according to the new guideline. And the next one is the issue of social workers. Let me appreciate that maybe we lacked to refer some of the clients. We're already referring, as Meram Dula has indicated, the issue of compliance, people who are not complying and people who are refusing initiation at some stage to the social workers. But I think we have missed at least referring everybody, once at least, so that somebody can be able vent out feelings. Ne? And the issue of the next one, the issue of I want to talk to the ones that are related to Maluti Apofin, the issue of harassment clinic. It's true, harassment clinic is short-staffed, but Mayor Hamdullah has indicated that an audit has already been done so that the department can see how do they replace the staff. The nurses at harassment clinic, they retired. It's not that people just left, but it's due to retirement that we are now short-staffed. And the issue of mobile services, there are some points that are not being covered by the mobiles around harassment. It's only 2 mobiles, and yet the farms are many. So we are running short of 1 mobile. It was supposed to be 3 mobiles around harassment. But what we have tried to do is to increase the number of farms for the other 2 mobiles, but we are still running short of providing for other farms. Okay, and then the other issue is the delivery of medicine in closed packages. It is true with the department, we were not closing the parcels because as the CHWs are distributing treatment, some are elderly women, so they have to explain how the treatment is being taken. But maybe with the new project that we are looking at implementing or the pre-packing of the medication for home delivery, I think it's going to address that issue of the parcels coming with enclosed in a parcel. Thank you very much. And really, we are looking forward to say when NHI is implemented, our facilities should be in good standing. That's our request. Even in the facilities, we are looking forward to making our services better. Thank you.
Good afternoon, comrades and colleagues. I'm Lindiwe Jogozela. I'm the acting local area manager for Dihlabeng. I would like, I'm sorry if I'm repeating what my colleagues have already said, but I would like to take this opportunity to acknowledge and appreciate the feedback that we get from Ritshidze. And the recommendations are noted, and actually we are speaking the same language. We are also advocating for our patients regarding several issues that we mentioned. I won't be long because if I can talk, I'll take the whole lot. I would like to speak to the staffing. Staffing, there are many issues that relate to staffing. One of them is attitude. Attitude is not an excuse. There is no excuse that we can treat our healthcare users badly. Remember, we are part of the society, colleagues. It's part of, whether you are infected or affected by HIV, your sister, your brother, your mother, your whoever is also part of the community. Uputi said we are using private services, but remember, if you and your family are using a private service, your brother and your sister are using the public service. So if you are treating your client with a bad attitude, it means you are treating your mother or your father with a bad attitude. The shortage of staff is the issue that we need to discuss, because that's the one that leads to the issues that we are having. Remember, our staffing are also humans. If you are in the facility and there's only 2 of you and you have to service 150 clients, obviously you're going to be overburdened and you're going to develop an attitude. So hopefully our provincial principals will hear our call to say, please give us the attitude after the staffing after you've made your audits to see if we can give the same service that the private is giving to our clients. So waiting time is a challenge, and we need to work together to work on the issue of waiting time. I heard we speaking about appointment systems and welcoming back policy. We need you as the community to assist us in order to implement the appointment system. So it's very difficult. I know my staff is also here. They know I fight every time to say, why don't you pre-retrieve the files? Why should a patient come and be turned back to say, we didn't get your file? It's not an excuse. We need to do the pre-retrieval of files. And we request our clients to also try to, I know it's difficult at times, especially if you are working to get a time off, but let's try to stick to our appointment, because if you didn't stick to an appointment, you are inconveniencing the person who's got an appointment for the following day. I will pass the others because Mekilan has already spoken to them. For an example, the art guidelines. Dihlabeng will be training now during September. The issue of key population. I would like Ritshidze to assist us. I've worked many provinces, and there was this training we used to get that was called diversity training. So if maybe you can support us so that we can train our healthcare providers so that they understand your point of view. And I think out of that, they will see the changes. The infrastructure in our facilities is very bad. And we are, as I said, we are advocating, we are writing submissions, and we are requesting for improvement in our facilities. Hopefully, something will happen out of it. Security challenges. Us as community, we said the clinics are ours, but if you know mamang utubile ko clinicing aidsing anga dipidis that we need to use, what are we saying about it? How are we protecting our infrastructure as the community? TB infection control. And TB and HIV, I think we are fortunate that 2 facilities in Thabo Mofutsanyana are selected to pilot the Putuma strategy. So it's Harrismith and Mbwadi. So we normally have our monthly meetings at the sub-district. We would like Ritshidze to be part of those meetings because we've got other partners like Bo, CCI, and Tulwana Emulimo that are advocating for you as well. So if maybe we can get details and invite you into our meetings so that we can plan together. What did I leave? I think that will be all for now. But we are promising that the staff attitude will deal with it. As May has said, the complaints should come to us. We've got the clinic committees that should be functional. But if we're not making use of the clinic committee, they will be non-functional. Remember, they are supposed to be a medium between the facilities and the community. Thank you.
Thank you, local area managers, and thanks to the colleagues who are in the room and the colleagues who have joined online. On the issue of Operation Phuthuma, ma'am, we really appreciate and welcome your commitment. There is Ujodi, she's gonna meet with you and she's gonna give you all the details of our colleagues who will be sitting in those meetings. On the issue of us training either at the facility or at the district level, staff to sensitize them on issues related to key populations, Unondlela is going to meet with you as we are working out to it, and you will make arrangements so that we can see how do we start working with you in trying to train them, because that will be part of sensitizing them. On the issue of people missing appointments, now I'm talking to you and the OPMs. Like we are saying on the report, one of us, all of us once or twice in a lifetime, we missed appointments. And the expectation is that that other person that we were supposed to meet to understand our situation. But when it's us, the users of the healthcare services, when we miss appointments, there are two things happening. One, either you are going to be shouted at and be treated like a child as if you are not stable mentally, or you will be made to stand right at the back of the queue. Because majority of the public healthcare users are God-loving people and peace lovers. They decide not to go to facilities so that they don't go through that frustration. And one even said, going to a clinic is like going to a hell because of what they are experiencing there. But me, as Anele, as a public healthcare user, I normally see when I go to a clinic that a clinic is busy from 8 until 1 o'clock. After 1 o'clock, clinic is not busy. They are coming back from the lunch, they are cleaning and doing all that stuff. So why don't we come up with a strategy to say all these people who missed their appointments, instead of them waking up early and queue there, let's make a standard arrangement to say after 1:30 or after 2 o'clock to 4, one of the things that we'll be doing is to attend to those people who missed their appointments. Therefore, it will mean if I missed my date 2 days back, I don't have to wake up early. I can do my chores and other things and know that after 1 o'clock, I will go to the facility and I will collect my medication, as well as the issue of pre-packing of medicines. So, on that note, I thank you, comrades, community members, Abahlali, for coming forward. I thank the department. I thank colleagues who have joined online. I thank the colleagues behind the scenes. I thank everybody, man. On that note, I don't know whether there are any announcements, but what I know, lunch has been arranged. So, unfortunately, we are a people's movement. So, in us, there is no thing like VIPs. All of us, we are queuing together. We are queuing together. You want to make an announcement? Yeah. But we are about to close, but...
Dumelang. Le kae? A nna ntate ne kopa fela ho botsa ka hore lubricant nyana di teng na kapa for no tjenana. Harassment. Mara no je se ke dula qoqo se ke tshwore no ja ke tswa mong ka khona ho tswala tse bo 15 nyana 10 nyana.
The question is going to be responded to. You're going to respond, ma'am? She is asking whether lubricants are available now, and when she goes to clinic, she can get them. Around Bethlehem, around Kobe, Kwakwa and Bethlehem.
At the facilities, but we'll speak with the Nati to make sure that it's available.
Thank you. So on that note, comrades, As I was saying, the meeting is coming to an end now. And I thank you all. And Umer is going to show us where we're going to queue and have ukudla. But we don't have tables. We are a community. We don't have VIPs. We're all queuing together as equals. On that note, the meeting is adjourned. Thank you very much.